what we mean by analgesia is that it should cause what? Loss of pain sensation. So we are going to learn about how the pain fibers, which we call nociceptors, propagate the pain information, and how the the local anesthetics are going to prevent that propagation of pain impulse. And then we will learn about how does inflammation cause the inactiveness of the local anesthetics. Okay, so first of all, we will discuss about pain propagation at the nerve, okay, by the nociceptor. All right, so let's just imagine. So normally this is how our neural fibers looks like, right? So we have some dendrites here. Then we have the cell body here with the nucleus. And this part here is the axon, and here is the knob. So whenever there is pain sensation can come from physical or chemical stimulation. So whenever these pain fiber, which is also called nociceptor, okay? Okay, whenever the receptors, okay, so the pain receptors will be under our body, which will receive the impulse of what? Pain. I mean, these are the dendrites. The receptors here will be receiving the impulse of pain. So normally it's not always direct like that. So we have some kind of receptors which will receive the information of pain and then stimulate the dendrites. Okay, so what is going to happen is that whenever these dendrites receives some impulse from the receptor, then it propagates the pain information. And in the body, this pain information is carried, in the central nervous system. Okay, first of all, this pain information will be carried through a peripheral nerve. Okay, and this peripheral nerve will send so in the spinal cord, we have okay. Okay, so then we have thalamus here. Okay. So when you stimulate the pain receptor, there is release of what? Intermediate neurotransmitters, which stimulate the dendrite of the pain fiber. Now, normally, most of these pain fibers are what we call pseudo-unipolar. They are pseudo-unipolar cells. So they don't look like this, rather they look like this. Okay, so I just drew. So what happened is that they will take the pain information to this part of the spinal cord. Now, a little bit of orientation here. When you divide the spinal cord, so assuming I'm dividing it in this small hole here is called the central canal. Behind the central canal is what we call the dorsal horn or the posterior horn. In front of the central canal is what we call ventral horn or anterior horn. So the inside part here, which looks like a butterfly, that is where I'm talking about. Over there, there are a collection of what? Cell bodies. Okay, so in the central nervous system, where there is collection of cell bodies, we refer to that as what? Nuclei. But when it comes to the spinal cord, we call it horn. So, horn. So the sensory information here, I mean, after this receptor has received, all right. So basically, we're talking about how pain is received by the brain as the sensation of pain. And I'm saying that, first of all, in our body, we have pain receptors, which sometimes we call it nociceptors, and we have the pain fibers. So the nociceptors can be stimulated by touch or chemicals. And when they are stimulated, they release neurotransmitters. These neurotransmitters are excitatory neurotransmitters. So what they do is that they will bind to their receptors on the dendrites of the pain fiber. And this neural fiber here will send that information first to your spinal cord. Okay, so I just drew this pain fiber here. Okay, and I said this pain fiber here is not a multipolar cell like what I've drawn here. It's rather a pseudo-unipolar. And the pseudo-unipolar means that they have one dendrite and one axon, but they don't look like the normal unipolar where the soma, which is the cell body, is found in between. Here we don't have one, it looks like only one fiber is coming and that fiber divides into two. Okay, so it doesn't really look like this one, where it is having one dendrite, one axon. So this pseudo-unipolar cell is part of those pain fibers, which is called sensory fiber. So when this pain sensation stimulates this fiber, which is now, this particular fiber is what I've cut here, is a sensory fiber. And I've already explained that the posterior part in terms of the central canal is called the posterior horn or the dorsal horn. The anterior part is called anterior horn or ventral horn. The sensory fibers, all sensory fibers, will send impulse through the posterior root, send their sensory impulse through the posterior root. And when they get there, all their cell body, these cell bodies will be surrounded by a connective tissue. And that connective tissue, because they are surrounded by a connective tissue, they form like a ball at the posterior part of the spinal cord. And that is what we call dorsal root ganglia. Okay? So when you see dorsal root ganglion, it basically means that we are talking about sensory fiber somas that have been surrounded by connective tissue. So it means that the one which is bringing the sensory information to the body here is the dendrite, and the one which the information is being transmitted through to the dorsal horn here is the axon. So when the information comes, it travels this way and gets to the dorsal part of the spinal cord horn, which we call the dorsal horn. Okay, we call it dorsal horn. Now, when it gets here, okay, when it gets into the horn, okay, and I said that the horn is a collection of what? Other cell bodies. And the outside part here is called the white horn, okay? And in the white horn, we have collection of what? Axons, okay? Myelinated axons, okay? So when the information gets here, there is another fiber here which will receive that information and cross it over here. This new interneuron is called commissural fiber. So it means when you receive pain sensation, the commissural fiber will cause the cessation of that impulse received from the pain fiber to the opposite side of the spinal cord. And from there, it will go straight to the thalamus. Okay? So you see, it got to the lateral part of the spinal cord. So this lateral part here, because it is getting to the other side of the spinal cord, and 8 axons are going straight to the thalamus, a nuclei in the thalamus. The nuclei is called the ventroposterolateral nuclei of the thalamus. So when it moves like this, so because it's moving from the spinal cord to the thalamus, and it's moving from the lateral aspect of the spinal cord to the thalamus, we call it what? Lateral spinal thalamic tract. Okay? Now, so that is the name of this axon which is going to the thalamus. Now, when it gets into the thalamus, from there, here, they are synapsing on another cell body like that, okay? And that cell body will send the sensory information to the cortex. Now here, for illustration purpose, I'm going to draw the brain cortex this way, okay? But actually, you can find your thalamus inside the hemisphere, okay? But we want to know exactly where this fiber from the thalamus is getting into in the brain. Now, we have the frontal lobe, okay? And in the frontal lobe, we have, from the frontal lobe, there is a sulci, or we call it sulcus. That is a deep indentation. You see, the brain is having outward projection and inward what? Projection. The outward projection is called gyrus. The inward projection like this is called sulcus. Okay? So we have gyrus, sulcus, gyrus, sulcus, gyrus, sulcus, like that. That is how the brain matter looks like. So in the brain, there is one of the sulcus is so deep that it separates the frontal lobe, okay? Separate the frontal lobe from the parietal lobe, because we have another lobe. This part here is called parietal lobe, okay? So this parietal lobe is separated from the frontal lobe by a sulcus, okay? And that sulcus is very deep, and it is extending to almost the lateral side of all these 2 lobes, and it is called central sulcus, okay? So the central sulcus separates the frontal lobe from the parietal lobe. Now look at something. Just in front of the central sulcus, there is a gyrus, okay? And that particular gyrus is so straight. It also goes straight, okay? Goes straight like that. And it moves from the top part of the frontal lobe to the lateral side of the frontal lobe. And this particular gyrus, because it is in front of the central sulcus, we call it what? Precentral sulcus. And they realize that this precentral sulcus, that is where all the cell fibers that are responsible for controlling our motor activity are located. So they also call it the motor area. Now, just after the central sulcus, there is another gyrus, which is like the precentral sulcus, because it also moves from upward towards the lateral part of the parietal lobe. So you realize that this precentral sulcus, said sulcus is not sulcus, it's gyrus, okay? It's gyrus. So realize that this precentral gyrus is part of the frontal lobe, and this new gyrus that we are talking about is called post-central because it is after the central sulcus. And this post-central gyrus is part of the parietal lobe. So, and they realize that that is where all the axons that are bringing information from all parts of the body synapse. So they called it the somatosensory area. Okay, so all the sensations that we feel in our body, first, when they are coming from any part of our body, they end up in the somatosensory area. So now let's come back to this diagram. We realize that this lateral spinothalamic tract is carrying an information from the opposite side of the spinal cord in terms of pain. Then it sends that information to the other side, okay, of the thalamus. And from there, another fiber moves from the thalamus to the cortex, and we call that tract thalamocortical tract. You know where they are going to synapse? At the post-central gyrus. Okay, so this tract is called thalamocortical because it's moving from the thalamus to the cortex of the brain. Okay, so the cortex, last time we explained that the part of the brain which is outside, okay, and it has collections of cell bodies, is called the cortex. Okay, so this tract here is called thalamocortical tract. What does that mean? It means that when the pain receptors are stimulated, that impulse is carried through the dorsal root ganglion by the pain fiber, and it sends it to the dorsal horn of the spinal cord. Then there is a commissural fiber which will receive that impulse and run it, send it to the opposite side of the spinal cord where the pain sensation is coming from. Then from there, 8 fibers goes up and synapse on the thalamus. Then from there, there are cell bodies over there whose axons are also going to the post-central gyrus or the somatosensory area. Then we will perceive the pain. That is how pain is perceived. Now, what we have to know is that how is it that that impulse is able to propagate along the fiber? And if we are able to know how it's propagating along these fibers, then we can stop it, right? So for the purpose of our discussion, because we are talking about local anesthetics, this part here going up to the brain forms part of the central nervous system, and this part here forms part of your peripheral nervous system. And in the peripheral nervous system, that is where we can use local anesthetics to what? To cause analgesia, to block the propagation of the impulse. So we are going to see how that impulse is generated. Now, so let's just assume this is the membrane of the pseudo-unipolar pain fiber, okay? And it is having receptors, or it is having some ion channels on it. So it will have receptors for chemical and ion channels, which can open when you physically stimulate it, okay? So we have the mechanical receptors and the chemical receptors, okay? These chemical receptors, once stimulated, will cause some ion channels to also open. What is going to happen is that for every neuron or for every muscle fiber, all cells have what we call resting membrane potential. Normally, the resting membrane potential for cells, neural cells, ranges between -62, -90, okay? Now, it means that the inside here is negative, okay? Because we have less positive ions here. And the normal positive ions here is potassium. And we have a lot of positive ions outside the neuron. And a lot of them are sodium and calcium, right? So for this cell, when it is at rest and it is not conducting any impulse, there is more negativity inside it and there is more positivity outside it. And because of that, it creates a potential, an electrical charge on its membrane, and that electrical charge ranges between from -60 to -90, and that is what we call resting membrane potential. Now, whenever you stimulate this fiber, either by touch or by chemical means, what happens is that there is an influx of some positive ions. Why? Because it causes those stimulations, either by touch or chemical, causes some positive ions to run inside, okay? When a positive ion like sodium comes inside, what happens? It means that you are moving from, so let's now assume that, okay, let's now assume that our resting membrane potential for this cell is -90. It means that whenever positive ions come inside, we move from the more negativity side to less negativity side, okay? So I'm going to draw a graph here, okay? And this graph is going to explain what we are talking about here. So first of all, we have -90. That is the resting membrane potential. Now we have another membrane potential. I'll talk about it as we go on. And probably it is at -70, okay? Now, for an action potential to be, or for an impulse to be generated along the fiber, we have to create an action potential. And how is that action potential going to be created? So this is what happens. So when you stimulate it by touch or by chemicals, positive ion channels open. And when these positive ion channels open, some positivity will come inside the cell and it will move the cell resting membrane potential from -90 to a less negative side, okay? However, on this same cell membrane, there are some ion channels, okay? There are some ion channels, a lot of them, a lot of them. A lot of them. Now, the difference between this one and that one is that this ion channel here can be stimulated by touch or by chemical means. But these ion channels here, we call them voltage-gated channels. Call them voltage-gated channels. Okay? What does that mean? It means that these positive ions that can come in as a result of physical or chemical stimulation, whenever this positivity gets inside the cell, at a point in time, the voltage in the cell changes. It goes up a bit. That means that the cell has moved from a more negativity area to a less negativity area. When that happens, it stimulates these ions to open. And these ions are what? Also, they are positive ion channels, okay? They are positive ion channels. So we can say sodium voltage gated channels or calcium voltage gated channels. So when first of all, when this positivity comes in and we reach at a point, then all these ions channels will open to allow more positive ions to come in. What happens? It means that the cell will now become more positive. The inside of the cell becomes more positive. And when that happens, we say we have created an action potential. Okay? And you will see how it is propagated along. But first, let's understand here. So what is happening is that when these positive ion channels are stimulated by touch or chemicals, they allow certain positive ion channels to come in. Probably it can be calcium, it can be sodium. So let's, because we are using sodium for this, let's change this one to be calcium. So calcium. So calcium will come in and naturally it will move from minus negative to a lesser negative side. Now, as they keep on coming in, then it gets to a point in time, okay, they reach to a level of about minus 70. It is at this minus 70 that all these sodium voltage gated channels will open. And so because they are all going to open, at this point here, we call it what? Threshold potential. Remember this one was called resting membrane potential. But at this point, we call it what? Threshold potential. Okay? What does that mean? It means that when you reach this potential, all these voltage gated channels will open to allow more positive ions inside. And there is no way you can stop the cell from generating an action potential. Okay? So what is going to happen is that once these calcium ions are coming in due to physical or chemical stimulation, you realize that the graph will be moving towards the threshold potential. Now, when it reaches threshold potential, all their gates will open. And you know what is happening? When their gate opens, they allow more positive ions to come in. And they close suddenly again. So they work at a very fast rate. They open all of a sudden and they close all of a sudden. So when you reach the minus 70, all these ions will open. And when they are open like that, more positivity will come. So we'll get a spike. And probably we'll even get us to about, let's say, positive 40. Okay? Now, when it gets to that point, okay, when it gets to that point, all the ions have closed. So when these ions closes, the positivity is inside, right? So what is going to happen? Now we have some ion channels also, which we call the potassium ion channel. Now remember we said that potassium is a lot inside here. And what will happen is that once you get to this level, plus 40, these ion channels will close, right? When they close, now this potassium ion channel will open and allow potassium to start leaving. When potassium starts leaving, okay, it means that positivity has started what? Leaving the cell. So the cell will start going into what? Negativity again. So you realize that the graph will start declining again. Okay? So it will decline, then gets to a point in time. Okay? Another thing that is going to happen also is that there is what we call, so it will, the positivity, the distance, what do we call it? The potassium ion will start leaving and it will leave until it declines and even goes below the resting membrane potential, okay? Once it gets below the resting membrane potential, we say that, oh, this cell has now been what? Hyperpolarized, okay? Why? Because potassium were leaving the cell. So potassium left and more positivity had left the cell, right? So once potassium leaves the cell, it will leave up to a point where it will send the inside of the cell to more negativity, to even more negativity than the resting membrane potential, probably to minus 100. And we say that at this level, we say that we have reached hyperpolarization, right? Now, when this hyperpolarization is reached, there is another surface protein, which we call sodium potassium pump, or we call it the sodium potassium ATPase. Okay, this sodium potassium ATPase, what it does is that it is having, let me draw it this way. It is having 3 binding sites for sodium, okay, and 2 binding sites for calcium. So the potassium. So the potassium side, okay, will bind 2 potassiums from outside the cell. Remember the potassium that left from the cell into the extracellular space, okay? So 2 of that potassium, okay, 2 potassium will be what? Shifted back into the cell, and 3 sodium will be what? Shifted from the cell back into the what? Into the extracellular space. So when that happens, what is going to happen? You are bringing in 2 positive ions, 3 positive ions. So there is a net loss of what? 1 positive ion. And that one will go on and on until we get what? The cell coming back into resting membrane potential again. So you understand this whole mechanism. Now I'll go through over it again so that we'll then learn how it is propagated. Now look at something. Resting membrane potential is the potential of a cell when the cell is not working. Now when the cell is not activated, or when the cell is at rest, it has a resting membrane potential of minus 90. Whenever the cell is stimulated either by touch, so here we are talking about the pain receptor. So remember, when you touch somebody, the person does not feel pain, right? When you keep on touching the person, then you squeeze or you pinch the person, then later the person experiences pain. So you just imagine, as you keep on pinching, some calcium will rush inside through the mechanical receptors, or the ions here. And that will move the resting membrane potential to a less negative side. So as you keep on pinching, more and more of the calciums will rush inside. And what is going to happen is that it will get to a point in time, we will get to what? Minus 70. And at minus 70, which we call the threshold potential, it will cause some ion channels on the membrane of the cell to open quickly to allow more positive ions inside. And when these positive ions rush inside, there will be a spike in the graph, and that is what we call action potential. Okay, so when that spike reaches to, let's say, plus 40, these ion channels here, which we call the voltage-gated ion channels, open fast and they also close fast. So they close, and then potassium ion channels on the membrane opens, and potassium will start leaving the cell, and then the graph will start declining again. In fact, potassium will leave will continuously leave until it bypasses the resting membrane potential and reaches more negativity, which we call hyperpolarization. When it reaches hyperpolarization, then the sodium potassium pump on the cell membrane is activated to pump 3 sodium out of the cell, then 2 potassium back into the cell until the resting membrane potential is achieved once more. That is how action potential is created on the cell membrane. Now from here, from the minus 70 to the plus 40, you see that it is climbing. We call that period, and you see from here it is declining. We call these periods refractory period. These refractory period, the one that is climbing, we call it absolute. We call it absolute refractory period. Okay? And what does that mean? It means that at this absolute refractory period, whenever there is some new impulse, it cannot create any action potential again. Okay? So the refractory period is the period within which action potential is occurring, and new impulse cannot create any further action potential. So in the absolute refractory period, that's the climbing part, when it doesn't matter the strength of the next stimulation, it cannot create another action potential. Then the declining part here is called relative refractory period. And in the relative refractory period, even though new action potential cannot be created, but when the stimulus is so strong enough, it can what? Create another action potential. Okay, so the difference is that in the absolute refractory period, it doesn't matter the strength of the stimulatory impulse, no action potential can be created. But the relative one, there can be another action potential based on the strength of the next impulse. Okay, so now let's learn how these impulses are propagated along the fiber. Now, what is happening is that, so along the fiber, so we now understand everything here. So I'm just going to draw a long axon here. So this is the long axon, right? And remember, axons not usually have vesicles which contains neurotransmitter. So let's assume that first the inside of the cell was more negative, right? And there were generation of impulses and it became positive. Remember that there are some voltage-gated ion channels. So when these voltage-gated ion channels open up and the inside of the cell becomes more positive, the other side of that same membrane, the voltage-gated channels will start what? Opening, and more positivity will come. And when the action, when the sodium potassium pumps start working, the inside will become negative again. So the preceding part will become negative. But the other part, the voltage-gated channels have opened and it has become more positive. And that positivity will also stimulate the neighboring membrane voltage-gated channels to open. So more positivity will come in. And the action of the ATP sodium potassium pump will cause the preceding part to become negative again. So it goes on and on like that. So this positivity will stimulate the sodium voltage-gated channels to open here, and more positivity will rush in, and sodium potassium pump will be activated, and here will become negative again. Sorry, I should do it this way. This part will become negative again, whilst the neighboring part becomes positive. So as the neighboring part becomes positive, the preceding part becomes negative. So it goes on and on like that. And that is how the action potential is generated along the neural fiber. Does anybody have any question here? If you have any question, let me explain it before I start. So we have now understood how impulse is generated along the neural fibers. And remember, on the axon node here, there is also a calcium channel, okay, which is also voltage gated. So whenever this positivity gets here, they will open and allow calcium to go inside. When calcium goes in, these vesicles, which contains neurotransmitters, okay, they will what? Cause these vesicles to fuse with the membrane and cause what? Exocytosis. So calcium will go and bind to the vesicles. Okay, so we have the VMP here, and we have the syntexin here. That the calcium will bind to the syntexin, because the syntexin is like this. It's like they are close, and the VAMP, okay, is on the vesicle. So when calcium binds here, they kind of open it, and now the vesicles can fuse in perfectly, and then will open up and allow the release of those neurotransmitters. There are receptors of host neurons here, okay, receptors who receive these impulse or these neurotransmitters to stimulate it and allow some positivity to go in, right? And the same reaction will repeat again and again and again. And that is how impulses are conducted along neural fibers. Please, does anybody have any question here? All right. So now I'm going to explain how. So now we understand how action potential is generated by the neural cells and how action potential is transmitted along the neural cell. So what we are going to do now is we are going to see how local anesthetics work, okay? So I'm drawing the same neural fiber again, where we have the mechanical channels which will allow positivity like calcium to come in. And we also have our voltage-gated channels, right? Now let me draw this one. This voltage-gated channel here is like this, okay? Yeah, like that. So there are lots, but you see, for the purpose of the discussion, I'll draw only one. So remember that this is how the calcium will come in, and when calcium comes in up to the level of what threshold potential, then this voltage-gated channel will open to allow more positive sodium ions to come in, right? But when you give someone local anesthetic, okay, these local anesthetics comes in the form of what? Weak base or salt. So why are they in the form of weak base or salt? When they are in the form of salt, okay, or weak base, local anesthetics, okay, when they are in the form of weak base or salt, they can now go inside here, okay? They can easily cross the bilipid membrane. See, local anesthetics, when they are in the extracellular fluid, normally the extracellular fluid is around 7.5. The pH is around 7.45, okay? But the pK, I mean the dissociation constant for the local anesthetics is around 7.5, okay? So here it means that these salts still exist in equilibrium. They cannot break down to release some positive ions, right? So when the extracellular fluid or the pH of the extracellular fluid is around 7.45 or 7.5, they don't dissociate, and then they are able to still cross the bilipid membrane. When you enter into the cell, the pH over there is 7.2. Okay, and in the cell, they are now able to dissociate to release some cations, some positive charges. And when they enter here and they dissociate, okay, to release that positive ions, then that positive ion can come and block this channel. What channel is that? The voltage-gated channels, okay? This is the voltage-gated gated channels. Okay, so remember we said that they exist in a weak, salt, salt form. But when they get into the cell, because the pH over there is low. Remember here, the pH over here is higher than the pH here. Okay, so when the pH here is low, they cause these local anesthetic in the salt form to dissociate and release some cations. And these cations can now block the voltage gated channels. And what does that mean? It means even if you stimulate this cell, okay, these voltage gated ion channels cannot allow more positivity to come in. And if that happens, it means that this cell cannot be stimulated, right? It cannot be stimulated. Why? Because it is the positivity that is coming from the numerous voltage gated channels that will allow this cell to achieve action potential. Okay, but if those voltage gated channels are blocked somehow, do you think the action potential will be achieved? No. So that is why how the local anesthetic works. In the extracellular fluid at a pH of 7.45, they are not dissociating to release these cations. But when they get inside the cell, and in the salt form, they can easily cross the membrane, okay? When they get inside the cell, because the pH over there is 7.2 and it's lower, then they can dissociate and release some cations, and those cations will block the voltage gated channels, okay? Now, whenever there is dissociation outside the cell, the cations cannot cross the bilipid membrane because they are polar, okay? So in what situation can that happen? Remember, in inflammation, what is going to happen is that there are release of certain acids. For instance, lactic acid. How? Remember that in inflammation, there will be edema, right? And whenever there is edema, there is also going to be what? Reduction in what? Oxygen supply, right? And whenever there is reduction in oxygen supply, even though vessels will dilate, more blood will move there, but there will be edema around the tissues, right? So there is going to be a reduction in the diffusion of oxygen across the membrane, and that will lead to what? The production of lactic acid from glucose, because glucose was supposed to have undergone glycolysis using aerobic means to produce what we call pyruvate, and pyruvate will be used to convert to form acetyl-CoA, which will enter into Krebs cycle, and eventually the NADH and the FADH2, which will be produced, will be sent into the electron transport chain for ATP production. But whenever the oxygen supply is low, it means that electron transport chain cannot proceed, so there is a backup. And then when there is what? A backup like that, it means that pyruvate cannot even enter into Krebs cycle again. And in that case, what is going to happen is that pyruvate is converted to the production of lactic acid. And this one is acidic. So when these lactic acid are produced, this lactic acid leaves the cell and they make the surrounding, the pH of the extracellular fluid lower, probably to the 7.2 or lower than 7.2, right? And remember that the local anesthetics comes in the salt form, okay? So now here the extracellular fluid has become what? Acidic. Why? Because of inflammation, okay? So in inflammation, there is what? Acid. Acidic what? Extracellular fluid. So whenever the extracellular fluid is having a pH below the 7.5, which is the pKa for the dissociation of local anesthetics, when it goes below, it means that this dissociation will occur at the extracellular fluid. And when that dissociation occurs at the extracellular fluid, remember we produce the cations outside the cell. Now these cations, because they are polar, they can't cross the membrane. And when they can't cross the membrane, they cannot also block the voltage-gated channels. So what does it mean? It means that in inflammation, or an inflammatory cell, or a cell which has, or a tissue which has undergone inflammation, there is decrease in the pH in the extracellular fluid, and we call it what? Acidosis. Okay, and because of that, these local anesthetics will dissociate in the extracellular fluid, and because they dissociated in the extracellular fluid, the active form, which is called the cation, cannot cross the membrane to cause the blockade of the voltage-gated channels. And because of that, these local anesthetic will not work. Okay, so in inflammation, there is acidosis. Local anesthetics will dissociate outside the extracellular fluid. And when they dissociate outside the extracellular fluid, they are not able to work. Okay, they are not able to work. So that is how you will say what they are going to. So basically what they said was that there wasn't hydrolysis of the to release the active substance of the local anesthetic. Actually there was, but it occurred at the wrong side of the cell. Then the local anesthetic should have gotten inside the cell to undergo that dissociation to release the cations, and these cations will now block the voltage-gated channels. Does anybody have any question here? Okay, so this explains the answer to the question. Please project the question again. Let me read it and let's answer it and let's move on. All right. So in case of inflammation, local anesthetic effect of novocaine decreases in strength. What process in the inflammation focus leads to disturbed hydrolysis of novocaine salt and therefore disturbed release of active anesthetic base? So here we are going to call it local tissue acidosis. And I believe you understand why the local tissue acidosis is the answer. Does anybody have any question? Else we can continue. Cindy, do you have a question?
No, please.
All right. So Abraham, can you please read the next question for us?
Question 2. The laboratory has received a sample of digestive juice for analysis. Its pH is 2.2. Name this digestive juice.
All right. So their screen. So some books will tell you that the pH of the stomach. So first of all, we need to know the digestive juices. Okay. So all the digestive juices here, some are coming from the stomach, some are coming from the pancreas, some are probably coming from, let's say, the gallbladder, because they also aid in digestion. So in the stomach, the pH of the hydrochloric acid is around 1.5, okay, to, let's say, 3.3. Okay, so it is highly acidic. However, when you get to the small intestines, I mean the duodenum, the pancreas release its digestive juice alongside bicarbonate. So you realize that by then, the pH over there will exceed 7. Okay, so the pH in the small intestines exceeds what? 7. And that makes it what? Basic in nature. And it is because of the release of what? Bicarbonate alongside it, right? So when they ask you a question that a digestive juice was having a pH of 2.2, obviously that digestive juice is coming from the stomach, and we call it what? Gastric juice. Does anybody have any questions? All right, please, let's move on. So the laboratory has received a sample of digestive juice for analysis. Its pH is 2.2. Name this digestive juice. And the answer is going to be gastric juice, D. Okay. All right. And the saliva too is quite basic in nature. It's not, and its pH is way higher than that 2.2. All right, so let's move on. All right, so Brian, can you please read question number 3 for us? Is Brian there? Maybe he doesn't.
One of the, can you hear me?
Yeah, I can hear you now.
Okay. One of the functions of central inhibition is the selection and reduction of the sensory information influx to the cerebral cortex. What type of inhibition performs this function?
All right, thank you very much. So bigger screen. So a lot of things are happening around us. Remember, you are wearing dress, okay? You are hearing some other sound. So a typical example is, let's say you are sleeping, okay? Maybe where you sleep or where your apartment is close to a railway station. And all the time, what is happening is that there is the train will be passing by, making a lot of noise, and its horn will also be blown, and that noise is so bad that it can disturb your sleep. But after some time, what happens? You're able to sleep, right? There is some kind of a filter in our brain which does that. So what happens is that whenever this impulse of noise coming from the train or the horn being blown, these impulses are prevented from reaching to consciousness so that you don't get stimulated by it. So that when you are sleeping, you don't hear the train making noise. But the first time you go to that place, your sleep will be disturbed, because that's the first time. And what is going to also happen is that your sleeping pattern will change a bit, but after some time it will return back to normal. So what is going to happen? Which part of the brain causes that? Now I'm drawing the brainstem here. So we have our midbrain, we have our pons, then we have our medulla, and we then come down as the spinal cord. Okay, so for instance, this is the spinal cord, like that. And then we have the cerebral cortex here. Okay, and remember we spoke about these structures here. We call it what? Thalamus, or the two are called thalami. Okay, now just see the thalamus as what? A relay center, where that every information that has to get to the cerebral cortex has to pass through. Okay, so it's acting like a relay center, with the exception of the olfactory nerve, which does not synapse here. All other information that has to go to the cerebral cortex, and once that information reaches the cerebral cortex, it reaches what we call consciousness. We become aware of that impulse. So remember I said, with the exception of what? Olfactory fibers, they don't give relay to the thalamus. Now, so for instance, the sound, the noise made by the train will come through your vestibulocochlear nerve, right? And they are found somewhere here, right? So the vestibulocochlear nerve are like that. We have the superior, inferior, lateral, and the medial side, right? So like that. So we have the superior, inferior, lateral, and the medial. So they are found somewhere here, like that, right? So whenever that information comes, okay, there is a collection of some cell bodies here. And remember we said that some collection of cell bodies in the central nervous system is called nuclei, because ideally the the collection of the central cell body should occur at the outer part of the central nervous system and call it what? Cortex, or the gray matter. But however, in the midbrain, there are a lot of collection of cell bodies, okay? In fact, these ones too are collection of cell bodies, so we call them nuclei. But there are discrete connection of cell bodies here, which every information that has to reach to the to cerebral cortex has to give some sort of fibers to it, okay? So this collection of, discrete collection of what? Cell bodies is what we call the reticular formation, okay? That's the reticular formation. And what does the reticular formation do? It filters the information that reaches to consciousness, right? So what happens is that reticular formation will receive some of the information here, even though some of the information from the vestibulocochlear nuclei, okay, that nuclei in the midbrain, okay, we call it the pontocerebral junction, will send it normal fiber to the thalamus. Then this thalamus will now give another fiber to our temporal lobe. That is where our hearing center is, okay? So this one, at the same time, it will give some fibers to the reticular formation. And what does the reticular formation do? It just bypasses the thalamus and then activates, okay? And then activates the cerebral cortex, okay? So what is happening is that whenever this sound is perceived by the receptors, or what we call the cochlear receptors in our inner ear, these receptors ideally should have stimulated the fibers coming from the thalamus to the temporal lobe so that hearing will be achieved. However, if the reticular formation doesn't want that information to reach consciousness, what it does is that it closes or it shuts down, okay? It shuts down the impulse that will have to activate the cerebral cortex, so that even the impulse will go, but over there is this strong inhibition over there, and that inhibition is causing the brain cerebral cortex not to perceive the impulse coming. How does that inhibition occur? So when that strong impulse of sound is coming, okay, there is going to be a spontaneous, because it is coming at a faster rate. So now let me draw another synapse here, okay? There is a synapse here. Remember that we said that whenever there is release of impulse, okay? Whenever there is release of impulse, so there is propagation of impulse, it releases neurotransmitters here, and assuming these neurotransmitters here, okay, are the neurotransmitters coming from the reticular formation to the cerebral cortex, right? So what is going to happen is that, first of all, whenever that sound comes, it comes at a faster rate. And what is going to happen is that because it is coming at a faster rate, it is going to cause strong stimulation here first. And whenever that strong stimulation occurs, the period of hyperpolarization. Remember we spoke about hyperpolarization. That's the point where after the nerve has been stimulated, then potassium will start leaving and it will send it to a period of hyperpolarization. At this period, the nerve becomes so much inhibited that it will be very difficult for you, excuse me, for you to stimulate it, okay? So after that strong impulse has come rapidly, this neuron here will become hyperpolarized. What does that mean? What it means is that this neuron has become so hyperpolarized that it can no longer stimulate the activeness of the cerebral cortex, because this neuron is going straight like those neurons that were supposed to activate the cerebral cortex. So when they activate the cerebral cortex, then the sound of hearing can be achieved. Okay, so this kind of filter, which causes us to be able to what? Sleep or maybe disregard other impulses. Okay, much of it is done by the reticular formation. Okay, so it filters the information that reaches to consciousness. And how does it do that? Because the impulses are coming at a faster rate, these neural fibers which are receiving the impulse in the first place will stimulate this neural fiber here, which was supposed to have sent the impulse to activate the cerebral cortex. But as they keep on stimulating this one becomes hyperpolarized, okay, because of the strength and the frequency at which they are being stimulated. And once they become hyperpolarized like that, it means that they become highly inhibited, okay? And this type of inhibition is called pessimal inhibition, okay? Pessimal inhibition. So this type of inhibition occurs in our central nervous system so that not all the informations that are coming to us will reach to consciousness, right? A lot of things are happening to us that it doesn't reach to consciousness because they are being filtered by the the reticular formation, okay? And for instance, when someone is talking and another person is talking and your attention is on that person, you realize that you're able to hear what that person is saying better than the other noise around you, right? Because the reticular formation is suppressing those information that are coming, which are not very important. Also, that is another function. But when you are sleeping, that is how the reticular formation works. Does anybody have any question? So I'm not going to write anything here, but I'm going to explain the other types of inhibition they mentioned in the question. So first of all, let's read the question and answer it. Then I'll explain the other types of inhibitions. So on the one function of the central inhibition is selection and reduction of the sensory information influx to the cerebral cortex. What type of inhibition performs this function? And the answer is A, pessimal inhibition. Now we have reciprocal inhibition. Reciprocal inhibition is the type of inhibition that works on agonist and antagonist muscles. So for instance, we have the biceps and the triceps. Big screen, please. So by now you understand this diagram very well. The spinal cord plus, all right? So sensory information is coming here. There is actually a ganglion somewhere here. And that information that is coming from the ventral horn is a motor information. And it is going to our muscles, right? So look at something. Whenever we have a muscle like this, and this muscle is probably an agonist, and we are having an antagonist. Okay, so for instance, its antagonist should be here, okay, which normally is not on the opposite side, it's on the same side, right? But I'm just drawing this one for illustration purpose. So whenever this muscle has to contract, right, the information will be sent to the dorsal horn, and there is an interneuron here that will give the impulses back to the motor neuron. This is usually alpha motor neuron, right? And this part here is the sensory neuron. However, look at something. Remember these ones to have their information coming from the dorsal part, which is the sensory, and the ventral part will send motor information back like that, right? So look at what is happening. There is an interneuron too. Now, the problem is that these interneurons, what they do is that they send an inhibitory fiber to the motor neuron here, and this one too will send an inhibitory fiber to the motor neuron here. What does that mean? It means that whenever you want this muscle to contract, that sensory information will be given to an interneuron, and that interneuron will give a stimulatory fiber to the motor neuron here to contract. But it will again give an inhibitory fiber to the motor neuron of the antagonist, okay, to relax it, okay? So it's the same thing. When this one wants to contract, it will give an information and to the interneuron, and that interneuron will give an excitatory information to its motor neuron to cause it to contract, while that same interneuron gives an inhibitory neuron to the motor neuron of its antagonist to relax. It's because it will inhibit it, and inhibition here means relaxation. And this type of inhibition is called reciprocal. Okay, reciprocal inhibition. You do me, I do you. That's the same thing. Okay, so the other one too, let me see the other. And we have presynaptic inhibition, and in the presynaptic inhibition, remember we drew the, wait, okay. Okay, so remember we drew this thing, the neuron like this, and there is a synapse, and there is another neuron taking that information, right? Goes on like that. Now look at what is going to happen. Now in the presynaptic inhibition, there are multiples of things that happen, right? This presynaptic neuron will be inhibited by another neuron, okay? How? So this neuron here is an inhibitory fiber, right? Somehow they are stimulated by this same neuron, okay? And once they are stimulated by this neuron, like this, they inhibit it, right? Or most of the time, they are not even stimulated by that neuron, but they are stimulated differently. So that this connection here is an axon to axon type of synapse, right? It will release some inhibitory fiber, neurotransmitter, usually GABA. And GABA will bind to its receptors here and allow more negative ions into this axon. And it will also cause what we call hyperpolarization, okay? Hyperpolarization. So remember we said that whenever positive ions like sodium gets into the cell, it causes what we call depolarization, right? Depolarization. Right? But whenever negative ions like chloride ions get inside the cell, they make the inside of the cell more negative, okay? More negative, just like when potassium was leaving the cell, okay? And whenever chloride gets into the cell, they cause hyperpolarization. Whenever potassium leaves the cell, they also cause hyperpolarization. And hyperpolarization here causes inhibition, okay? Hyperpolarization causes inhibition of that particular neuron. The only neuron which will be activated by hyperpolarization is our optic nerves, okay? All right. So that is the presynaptic inhibition. So the presynaptic ganglion. So normally, because this one is called, this part here is called synapse, right? Synapse. Because this neuron is before the synapse, we call it what? presynaptic neuron. Okay. And this neuron is after the synapse. We call it what? Postsynaptic neuron. All right. So when we say presynaptic inhibition, there is an inhibitory fiber onto the presynaptic neuron, and it causes inhibition of that neuron. That's the presynaptic inhibition. Now let me see that inhibition, and then think I have to explain that last one. So the lateral inhibition, okay. The inverse inhibition, I'm not going to explain that one. Okay, so look at something. Just imagine this is our skin, okay? So this is the skin. Now you have a sharp pin, right? A very sharp pin. Then you touch or you pierce only some small portion of the skin, okay? But remember that around these points, okay, there are some neural fibers, okay? These neural fibers here, okay, they are around where exactly where the damage was occurring. And this is where the damage has occurred. Now remember that when you pierce somebody with a pin, there are release of other chemicals also which can stimulate all these fibers. It is not only this particular area that can be stimulated, right? So what is going to happen is that whenever that happens, so remember these fibers are usually unipolar, pseudo-unipolar, right? They are pseudo-unipolar. So what they do is that they also stimulate a multipolar. Okay, so I'll do this to represent multipolar. They stimulate multipolar cells, okay? So this one too will stimulate a multipolar cell, okay? This one too, multipolar cell. And these multipolar cells will in turn stimulate other cells, right? So just imagine. So look at it. Remember that from the spinal cord, we have a sensory fiber which is coming into the spinal cord, and then there is a spinothalamic tract which will send the impulse to the thalamus, and from the thalamus to the cortex. So just imagine those arrangement, we call it first order neuron, okay? This one here becomes second order neuron, and the last one here becomes third order neuron. These third order neurons are the thalamocortical tract. These are the ones that will send the information to our somatosensory area, the brain. So look at this one. These are the sensory fibers which are bringing the information to the spinal cord, and these are the fibers that are sending the information to our thalamus. What they do is that when they get into the spinal cord, there is some kind of inhibition, right? Because we want to know exactly where the damage is occurring, okay? So that when they ask you to close your eyes and point where the needle shears, you can even close your eyes and point exactly where the pain was, okay? So this is what is going to happen. Remember that pain that occurred is first diffuse, right? So these receptors too are stimulated. They carry that information to their interneurons. Now look at what is going to happen. Because this one was hyperstimulated because of a direct contact with where it was being stimulated, they will give an inhibitory fibers laterally to its parallel fibers. Okay, so they will send an inhibitory information to 8 parallel fibers. What does it do? It cancels the transmission of impulse here to where the sensory information should have gotten to consciousness. But the pathway where it leads to exactly where the pain was stimulated will be allowed to go through. Okay, so when it gets to the spinal thalamic tract level, it inhibits its parallel fibers. And the exact place where the pain is, it allows the pain to go through. Okay, and this type of inhibition is what we call the lateral inhibition. Okay, inhibition. Now with the inverse inhibition means that something that should have caused excitatory will lead to what? Inhibition, right? So it doesn't give you a very clear, and something which should have caused inhibition may give you excitation. That is the inverse inhibition. But the first three that I explained are very important, and that is why I took my time to explain it, and because they usually come in the Krok. Does anybody have any question? All right. So the question is, we've already answered the question, right? So let's move on to question number 4. And Fatuma, can you please read that question for us?
A woman was diagnosed with peptic ulcer of the stomach. She has a long history of rheumatoid arthritis. The peptic ulcer, in this case, is most likely to be caused by a long-term taking of the...
All right, so bigger screen, please. All right, so what is happening is that when we say someone is having peptic ulcer disease, it means that the person is likely to have some ulcers or some sore in the stomach mucosa. Now remember, the stomach is having a mucosal lining, okay? It is having a mucosal lining. We've spoken about this thing before, but for the purpose of those who are joining us recently, let's repeat it again. So it is having a mucosal lining, and what does that mucosal lining do? What it does is that there is production of what? Mucus. And this mucus is having a lot of what? Bicarbonate in it. And what does it do? It kind of what neutralizes the effect of the acid produced by our parietal cells. Okay, so the mucus produced here is able to protect the mucosal lining of the stomach. When these mucus are being produced, they need prostaglandin. Okay, they need what? Prostaglandin for its production. Okay, so it means that no prostaglandin, no mucus, right? And when that happens too, there can be now ACL, when there is no mucus or poor mucosal lining development, then acid can easily act on this and cause what we call an ulcer. Okay, so it means that if you don't have prostaglandin, you can't produce mucus, and the mucus too serve as a protective layer against the acid which is being produced in the stomach. Now look at something. Prostaglandin production here is in two forms. We have the body needing prostaglandin for its normal activity. So it stimulates the cells spontaneously to produce prostaglandin for its activity. And whenever our body too is undergoing damage, okay, through an inflammatory process, then there is also production of what? Prostaglandin, right? Now let's look at how the prostaglandin is produced from the cell. So whenever we block the production of prostaglandin, it means that we will have what? Stomach ulcer. Likely we will develop stomach ulcer. So first, let's see how we produce the prostaglandin from the cells, and then let's see how the prostaglandin can be blocked, right? Okay, so first of all, on the membrane of our cells, we have what? We have lipid membrane, right? Now, lipid membrane here, okay, the lipid membrane here, there is an enzyme called lipase A2, which is actually found inside our cell. right? Now this lipase A2, whenever our body needs to produce prostaglandin, it is stimulated. Another way that this lipase A2 is also stimulated is when the body has undergone some damages. You understand? And what is going to happen is that this lipase A2 will break down some of the lipid, okay? The lipid, okay? So let me make it this way. So remember that lipid is made up of what? The glycerol plus what? Free fatty acids. So 3 fatty acids, 1 glycerol, okay? So what this lipase A2, okay, lipase A2 will do is that it will go and break some of the free fatty acid away, okay? And normally that free fatty acid that it breaks away is the arachidonic acid. Arachidonic acid, right? So when it breaks down the lipid, it releases what? Arachidonic acid. So just imagine that fatty acid that went away is the arachidonic acid. So it releases arachidonic acid. Now what happens? These arachidonic acid too can be acted upon by different enzymes to produce different products, right? Now remember we said that our body normally needs what we call prostaglandin for a lot of activity, not for the mucosal production only, but also for the function or the dilatory function of the vessels supplying our kidneys, right? So what is happening is that this arachidonic acid will be okay. So this enzyme is called cyclooxygenase. So we use COX to represent it. So we will have this COX enzyme acting on it to convert arachidonic acid to what? Prostaglandin. Okay, I'll use PG to represent prostaglandin E1. This is normally the prostaglandin that we need in our body, right? For this mucosal production. And whenever we need that pathway, we stimulate this pathway. First, we stimulate there is a signal to the lipase A2 to break down lipid to release what? Arachidonic acid. This arachidonic acid is again converted to prostaglandin using COX-1, cyclooxygenase 1. Now, this same pathway can be activated, okay, when there is damage occurring in our body, right? Damage like an inflammatory process going on. And in that case, there is activation of another cyclooxygenase enzyme plus the first one. So COX-1 and COX-2 are all activated to release prostaglandin. Okay, so we realize that here it is inflammation specific, right? Even though this one is not specific to inflammation, but during inflammation, it also gets released, right? Now, there is another enzyme which we call the lipoxygenase, okay? And this lipoxygenase, okay, so I'll use LOX to represent that one. So this lipoxygenase, when it acts on the arachidonic acid, we produce what we call leukotrienes. Okay, these leukotrienes causes our smooth muscles to contract. Okay, smooth muscle contraction. Okay. Now, what is happening is that when you release a lot of leukotrienes, it will cause your bronchial smooth muscles to contract, and an asthmatic attack will be initiated if the person is an asthmatic, or bronchospasm will occur. Okay. So this is how we produce this prostaglandin. Leukotrienes can also be produced by a different enzyme, which is called lipoxygenase. Now see, so it means that whenever we want to produce them, because lipase A2 has to be activated so that arachidonic acid will be produced. And when the arachidonic acid is produced, we can produce the prostaglandin E1 using the OX1 pathway, right? Now, there is a hormone in our body that can inactivate the activity of lipase A2, okay? And this is called cortisol, okay? Cortisol inactivates activity of lipase A2. So it means that cortisol will inhibit the activity of lipase A2, and that means that the lipid will not even be dissolved to release arachidonic acid at all. If we don't have arachidonic acid, we will not produce what? Prostaglandin. You understand? So that is one pathway, right? And for the purpose of our discussion, I will stop it here. So let's look at the activity of cortisol on lipase A2. It inhibits lipase A2 so that lipid cannot break down to what? Arachidonic acid. And if we don't have arachidonic acid, we can't produce prostaglandin E2. And if we, E1, sorry. When we don't have prostaglandin, we cannot produce mucous membrane. And this mucous membrane, when we don't have it, acid will now work on the mucosa and we get our stomach acid. Okay? This cortisol is also called what? Glucocorticoid. Okay? Glucocorticoid steroid cause anything. Okay? Now, look at something. They have artificial forms like prednisolone, hydrocortisone, and we also have what? Dexamethasone. There are a lot of them. Betamethasone, triamcinolone, a lot of them. Okay, so now the question was saying that someone who was suffering from chronic disease and the patient was kept on a drug, and that drug led to, I don't know, was that how the question? Please project the question and listen. Led to stomach ulcer, and that means that the person was taking one of these drugs. Now, let's read the question again. The woman was diagnosed with peptic ulcer disease of the stomach. She had a long history of rheumatoid arthritis. So, rheumatoid arthritis, the peptic ulcer in this case, is most likely to be caused by a long-term taking of the glucocorticoids. And the answer is A, glucocorticoid. Now, please give me a bigger screen. I've now seen the question. Let me just explain this part also. Now, so the question was saying that the patient was having arthritis. So it is an inflammatory process, right? So it means that this COX-2 cannot lead to the production of this. And you see, what happens is that when you produce prostaglandin in inflammation, what it does is that it stimulates pain fibers. It causes dilation of vessels and edema will occur. So in inflammation, prostaglandin play an active role in inflammation. And inflammation of the joint is called arthritis. So for you to prevent that inflammation, you give a drug that will prevent the production of prostaglandin, right? And the drug that they are saying was given. Now listen, in that question, they were specific. They didn't give any drug that will confuse you. So the answer was what? Glucocorticoid. Now let me explain something small here. We have some drugs that can block here, COX-1 and COX-2. And those drugs are called non-steroidal anti-inflammatory drugs. Example is what? Diclofenac. 2. We have ibuprofen. Okay, we have a lot of drugs, naproxen. Right? Now look at something. So those drugs that can block both COX-1 and COX-2 are called what? COX non-selective. Okay, they are non-selective. They just block COX-1 and COX-2. And example of such drugs are diclofenac, ibuprofen, naproxen. So it means that this same woman could have been given any of these drugs, right? If they had not given her the glucocorticoid. What does that mean? It means that next time the same question will come. They might not bring glucocorticoid, but they might bring any of these drugs. And look at what they do. They inhibit the activity of COX-1 and COX-2. And that means that prostaglandin will not be produced at all. And mucosa 2 will not be produced. Also, okay. It's the same thing. So when they don't bring the glucocorticoid steroid or any of these drugs here, prednisolone, hydrocortisone, dexamethasone, but they bring diclofenac or ibuprofen or naproxen, that will be the answer. Now look at some wise drug here. That wise drug will block only COX-2. Why? Remember I said that COX-2 is stimulated when an inflammation is going on. Okay? So when we want to reduce the production of the prostaglandin which are being produced, but we don't want to disturb the normal pathway which will lead to the normal production of that prostaglandin that will be needing to what? Form mucous membrane. Then we give that drug that can selectively block that COX-2 which is responsible for the production of prostaglandin during inflammation. That means that if you give that COX-2 blocking drug, it will not have any effect on the stomach. It means that prostaglandin here by the COX-1 can still go on, production can still go on, and mucosa can still be produced. And when the mucosa is being produced, then it means that this patient here can have mucous membrane and it will protect the stomach. So such a wise drug, we call it what? COX-2 selective. We call it what? COX-2 selective. NSAID, right? So it means that they are also non-steroidal anti-inflammatory drug. Why? Why do we call them like that? Because these drugs are steroids. Okay, so they are steroidal anti-inflammatory drugs. But these ones here are non-steroidal, they are not steroids, but they can also cause anti-inflammation. Steroids can cause anti-inflammation. Other drugs which are not steroids, you can cause anti-inflammation. These drugs here are non-selective, COX non-selective. And we are talking about the COX selective. So in COX selective drug, we have celecoxib, right? So we have celecoxib. Now here we have another important drug that's available, right? Aspirin. Okay. The non-selective part, we have aspirin or acetyl salicylic acid. So when the question that we have now appears in the Krok, and they don't bring glucocorticoid drug, but they bring prednisolone, hydrocortisone, dexamethasone, any of them could be the answer. If they don't bring any of this at all, and they bring any of these non-selective NSAIDs, then they can be the answer. Okay? That will be the answer. But when they bring this NSAID here plus this NSAID here will not cause stomach ulcer. So this one cannot be the answer. Do you know when this celecoxib should be the answer? When they tell you that already the patient is having what? Stomach ulcer. So which of these NSAIDs can the patient take without exacerbating the ulcer? Then you can select the celecoxib. I repeat it again. This celecoxib here will not exacerbate somebody's ulcer. It is selective to COX-2, so it blocks only COX-2, which is activated during inflammatory pathway. So if someone is having stomach ulcer And the patient is again having what do we call it? Inflammatory process like arthritis. And they ask you, which NSAID can you prescribe to the patient without exacerbating the ulcer? And even if you are practicing, okay, this is for practical purpose. If someone comes to your consulting room and the person is having stomach ulcer, you don't go and give the patient these non-selective COX drugs or these steroids. You only worsen the patient's case. You rather have to give, if the patient is having ulcer plus an arthritis or inflammatory process, you rather have to give celecoxib. Celecoxib is COX-2 selective NSAID. And what does it do? It will prevent or bring down the inflammation, but will not have any adverse effect on the stomach. Okay? So when they ask you which of these NSAIDs is good for someone who is having ulcer, then you take what? Celecoxib. Now let's move on to the next question, please. All right. So we will talk about the question number 5 and go on a break and come back. Okay. So, Bright, can you please read question number 5 for us?
Yes, sir. A man with chronic constipation was taking daily 1 tablet of bisacodyl. After a time, he has to start taking 2 tablets daily to achieve the same effect. This type of change in the action of active substance is called.
All right, thank you very much. So here I'm going to explain the answer. So here the answer is going to be habituation. I'll explain why the answer is habituation. Then we'll talk a bit about the drug dependency. Then we'll talk about idiosyncrasy. Then we'll talk about accumulation and sensitization verbally, okay? So that it will be a bit fast. So can you please give me a bigger screen? So the answer is habituation. Why? Whenever someone takes a drug and develops some kind of tolerance to that drug and will require a higher dose of that drug before its effect is achieved, then we say that the person has developed habituation to that drug. Okay? So habituation here, let me write it. Habituation is tolerance, okay? Tolerance to the effect of drug acquired through drug acquired through continual use, okay? Continual use. Now, let me explain what tolerance here means, okay? So, when we talk about tolerance, it means that the person requires a higher dose of the drug to produce the same effect, okay? So, remember, habituation is tolerance to the effect of drug acquired through the continual use. So, it means this patient who was taking bisacodyl, and bisacodyl here is what we call a laxative drug, okay? It allows you to free your bowels. If you have constipation, you're able to free your bowels when you take bisacodyl. So at a point in time, this patient needs to increase the dose of the bisacodyl, then we'll be able to experience bowel movements, okay? Whenever that's a situation occurs, then we call it what? Habituation. All right. Now, please pay attention. I'm going to explain other ones by reading it to you so that you know what they mean. Sometimes you hear the word tachyphylaxis. Okay. Tachyphylaxis is defined as the rapid decrease in response to repeated doses over a short period of time. So when they say, okay, they give the drug to the patient and after the next dose, they have to increase it. So you see the similarities between tachyphylaxis and habituation. So what I've realized in the Krok is that sometimes they bring a question which you might be thinking the answer is tachyphylaxis, but have not seen that they've ever brought both habituation and tachyphylaxis together. So what does it mean? It means that next time when they don't bring the habituation and they bring tachyphylaxis, that will be the answer. Because look at the definition of tachyphylaxis. It is defined as the rapid decrease or in response to repeated doses, okay, of drug over a short period of time. You understand? It's like the person has developed tolerance to that same drug, okay? So they are very similar, and in the Krok, normally either they bring habituation or tachyphylaxis. When they say that someone took some drug and after some time they need to increase the dose before the same effect can be achieved, then the answer can be habituation or tachyphylaxis, okay? Now, when we talk about drug idiosyncrasy, see, we all take a drug like, I can take a drug like quinine. Nothing will happen to me. But when somebody is having a condition like glucose phosphate dehydrogenase deficiency, then this person, once the person takes that same quinine, the person will start hemolyzing the red blood cells. Why? So, because the person is already having an enzymopathy, an underlying enzymatic defect, that is why the patient is reacting badly to the same drug that any other person can take, and there wouldn't be any reaction. So they say that idiosyncrasy refers to reaction to drugs that occur in small fraction of patients and have no obvious relationship to the dose or the duration of the drug, okay? And we have drug dependency. It's an adaptive state that develops from repeated drug administration and which results in withdrawal syndrome upon cessation. So when we say that someone is having drug dependency, it's the same as saying the person is addicted to the drug. So when the patient will take that drug for a period of time. And at a point in time, when the patient does not take that drug, the patient will feel some kind of uncomfortability in their body, okay? Like itchiness, like restlessness when they don't take the drug. But when they take the drug, then they become what? Okay. Then in that state, we say the person is addicted to the drug, or we say drug dependency. Now we also have drug relation. So remember that there are some drugs that when we take, okay, because of the way it pharmacokinetic activity, it takes a very long time before it is excreted from our body. However, when we take the normal dose of that drug, okay, and probably due to an underlying condition, or probably even you are healthy, but because the drug can be stored for a very long time, and you are still taking the drug at the prescribed level by the doctor, or you being the doctor, you prescribe the drug normal to the patient, yet the patient comes back with overdose of that drug because there was an underlying condition, like the liver was supposed to have detoxified the drug, and the kidney was also supposed to have excreted the drug. And because of dysfunction of those organs, the drug cannot be excreted appropriately, or the drug is always stored in the body. So in that case, even when the patient is taking it at the normal dose, the patient will experience accumulation of that drug. the toxicity level of that drug. And for instance, an example of said drug is digitoxin. So in the Krok, normally they bring digitoxin, okay, that someone who had chronic heart failure was given what we call anotropic drug, okay? And this drug, what happened was that the patient started experiencing disturbed color vision and other presentations. What kind of problem is the patient experiencing? Then your answer is likely to be what? Drug accumulation, okay? Or we call it accumulation of drug. And the last one here is sensitization of drug. And drug sensitization occurs in drug addicted and is defined, it occurs in people who have drug addiction and is defined as the increased effect of drug function, increased effects of the drug response, increased effect of the drug effect because of the repeated doses, okay? So you realize that the drug sensitization has similar characteristics like the dependency because they all occur in people who are addicted. Does anybody have any question here? All right, so please let's go for a break and we'll return after the break. All right. So, Aure, can you please read the question for us? Question number 6. Can they hear me? They can hear. Can anybody hear me?
Yes.
All right. So, Aure, please read the question.
The process of collapse progression is associated with dysfunction, disturbed pulmonary gas nervous system exchange, and disturbance in the system of blood and hemostasis. These signs of collapse are caused by initial development of the following type of hypoxia.
All right. Nervous system exchange, nervous system dysfunction, then pulmonary gas exchange. You get the point. So first of all, the question is saying that the progression of collapse. So when we talk about collapse, here it means that there is a sudden loss in muscle tone, okay, which is associated with either loss of consciousness or not, okay? It's associated with loss of consciousness. So the causes of collapse are a lot, okay? The causes of collapse, we can have a cardiac cause, okay? We can have hypovolemic cause, hypovolemic cause. We can have the hypoxic cause, okay? Now, In the hypoxic cause, sometimes it may be due to someone who is ascending to higher altitude. Okay, and you remember last time we spoke that in higher altitude, the oxygen, partial pressure for oxygen is low. And in that case, it means that the person will not get enough oxygen into the blood, and that will lead to what? Hypoxia. Okay, and this hypoxia, so this question here, they didn't specify the cause of the collapse. However, they made us aware that, like from the answer options, we realized that it was hypoxic cause, right? But in this type of hypoxia, they didn't also give us any clue as to whether what was causing the hypoxia. You understand? So we are just going to assume that the hypoxia has occurred. We don't know what is causing the hypoxia. But what is the effect of the hypoxia at the tissue level, right? Because they didn't give us any clue as to what caused the hypoxia. But they gave us some clinical presentations which are associated with nervous dysfunction, poor exchange of gases at the pulmonary level, and hemostasis disturbances. These are characteristics of tissue hypoxia, okay? Because in the nervous system, when there is hypoxia, at the tissue level, what is going to happen is that there is going to be cerebral edema. Why? Because in hypoxia, there is increase in there is going to be dilatation of the endothelial cells, okay, the spaces between the endothelial cells, and that will allow fluid to seep out of the vascular chamber into the interstitial fluid, right? Remember that in the blood-brain barrier, the endothelial cells are connected by tight junctions. But during hypoxic state, that tight junction over there is breached, and fluid can now leave the cell, okay? So there is usually tight junction in the endothelial membrane, but during hypoxia, there will be some spaces created between these endothelial cells, and fluid can now leave, and then they will fill the extracellular space. I mean, the interstitial space of the extracellular, because the vascular chamber is part of the extracellular space. So I'm talking about the space between the vessel and the neural cells. That's the interstitial space. And that is what we call cerebral edema. When cerebral edema occurs, they present with a lot of neurological dysfunctions, okay? This patient can have convulsion. This patient can have raised intracranial pressure. And this person can have sudden loss of functions of some parts of the bodies, okay? However, remember I said that there is what? Dilatation of the vessels and the permeability of the endothelial cells in the brain for hypoxia, okay, at the tissue level. Now, in the pulmonary level, it is rather going to cause pulmonary vasoconstriction when there is hypoxia. So when there is pulmonary vasoconstriction, what is going to happen? What is going to happen is that the flow of blood, so this is the lungs, right? And we should have some blood vessels coming for exchange of gases to occur here, right? But there is sudden what? Vasoconstriction. Okay, so if there is sudden vasoconstriction, do you think enough blood can even flow here for exchange of gases to occur? No. So At the tissue level, these are the changes that will occur in the vascular chamber. And at the same time, because of lack of oxygen, the metabolic pathways are also going to be deranged. You understand? The derangement of the metabolic pathway, especially in the endothelial cells of the cerebral blood vessels, that led to dilatation and also increase in the spaces between the endothelial cells. Ideally, there shouldn't be any space between them, okay? Because they release certain substances, okay, which we call them the local vasogenic effects. So what is going to happen is that they release certain substances like what? Lactic acid. You are going to release carbon dioxide. You are going to release a lot of these substances, and these substances will cause what? Vasodilation over there. But that same vasodilation does not occur at the pulmonary vessel. Rather, in the pulmonary vessel, there is vasoconstriction. And that will be a topic for this discussion, another day for discussion. But you realize that there will be what? Nervous system derangement and also poor exchange of gases in the pulmonary chamber, okay? And that is what we call tissue hypoxia. Now, can you please project the question? Does anybody have any question here? The question. The arrangements in them. Okay. So there is a bit of misarrangement here. The process of collapse progression is associated with dysfunction. Dysfunction of nervous system. That should have been the way the question should have been. Okay, it should have been dysfunction of nervous system and disturbed pulmonary gas exchange. Okay, it shouldn't be the dysfunction. So probably we are trying to correct it now. So we realize that first there will be what? Nervous system dysfunction, then there will be disturbed pulmonary gas exchange. And disturbance in the systems of blood and hemostasis. These signs of collapse are caused by the initial development of the following type. So they said A, hypoxic hypoxia. See, in hypoxic hypoxia, they should give you a clue that the patient had some respiratory problem. Because of that, okay, like the patient is actually having a respiratory disease, all right? And because of the respiratory lack of that, because of that respiratory disease, there is lack of exchange. So for instance, it has led to what? Pulmonary edema. Probably the person is having chronic bronchitis, some pneumonia, and the patient has experienced yes, the process of collapse progression is associated with nervous system dysfunction. Yes, that is how it's supposed to be. Okay. So with the hypoxic hypoxia, what is going to happen is that the patient.
The continuation.
No, I don't need this thing again. I don't need the question. So I was explaining the hypoxic hypoxia. In the hypoxic hypoxia, what is happening is that there should be a respiratory system disease, like bronchitis, emphysema, like asthma, pneumonia, that has led to poor exchange of gases. And because of that poor exchange of gases, it has led to what? Hypoxia. Hypoxia is what? Reduction in the partial pressure of oxygen in the blood. Okay? Or we can say that the poor oxygen saturation in the blood, right? Now, in this situation, we will call it what? Hypoxic hypoxia. But I realize that in the question, please the question. You realize that in the question, they didn't make mention of any respiratory infection. Okay, these first started with nervous system dysfunction, and the next one is tissue hypoxia, which I just explained. All right, and so the respiratory hypoxia here, it comprises of whether the person has respiratory disease or the person has ascended to some level of altitude, okay, where there is difficulty in exchange of gases. And the hemic hypoxia here refers to the fact that there is a problem with the hemoglobin which binds to the oxygen. So for instance, when someone is having carbon monoxide poisoning, carbon monoxide loves the hemoglobin. It has higher affinity to the hemoglobin than the oxygen. So what is going to happen is that this patient will have normal oxygen supply, but because carbon monoxide has already occupied the space in the hemoglobin, the oxygen will not get a place to bind. And in that case, the patient will not have enough oxygen in their blood, right? And that is the type of hemic hypoxia. It is having problem with what? The red blood cell. And we have a situation we call the methemoglobinemia. You know, the hemoglobin should be in the ferrous form, not in the ferric form. It should be Fe2 plus form. But in people who are having methemoglobinemia, they are iron in the core, in the hemoglobin, the protoporphyrin ring in the center. So give me a bigger picture and let me just explain that one. So I'm just going to draw some simple structure of the hemoglobin here, okay? So just imagine this structure here. One of this is called pyrrole, okay? One of this is called pyrrole. But when they form a ring, okay, we call it what? Protoporphyrin. Or they sometimes call it porphyrin, okay? Protoporphyrin ring, okay? Now in the center here should be iron. And in the normal hemoglobin, it should be what? Fe2 plus. This here is what we call hemoglobin, okay? Hemoglobin. Now, sorry, it's hem, right? This one here is called hem. But if it is having the globulin chains attached to it, then we call it what? Hemoglobin, okay? So the globulin chain for the adult type of hemoglobin, we have 2 alpha chains, 2 beta chains, right? Now, this is the normal hemoglobin, right? But in some situation, this Fe2 plus here is changed to what? Fe3 plus. In this situation, what it means is that this hemoglobin already is what? It cannot bind to oxygen, okay? In this situation, this hemoglobin here cannot bind to oxygen. And when it cannot bind to oxygen like that, it means that we call it has already been what? Oxidized, okay? Fe2 plus is the reduced form, and Fe3 plus is the oxidized form. So here, the Fe3 plus cannot bind to oxygen. And when it happens in this way, we call it methemoglobin, okay? Call it methemoglobin, okay? So it's a scenario that usually occurs in our body all the time, but there are some drugs that when you take, you can develop a lot of methemoglobin, okay? And such drugs are the organic nitrates, okay? Like nitroglycerin, isosobide dinitrates, and stuff like that. So when it happens like this, it means that this hemoglobin cannot bind to oxygen. And if it doesn't bind to oxygen, it means the red blood cell is useless. It cannot carry oxygen to the tissues. And in that scenario, we call it what? Hemic hypoxia, Okay, give me the questions. Okay, so the circulatory hypoxia has something to do with probably circulatory collapse when the heart is not able to pump enough blood to the tissues, or there is an occlusion of the vessels. Okay, then the blood cannot get there, so there is what? Hypoxia. But you see, all these types of hypoxia will eventually lead to what we call tissue hypoxia. And there is the tissue hypoxia that will have these clinical manifestations. Okay, does anybody have any question? All right, so let's move on to question number 7. Blessing, can you please read question number 7 for us?
Okay. After partial pancreatic resection, the patient develops steatorrhea, which indicates disturbed digestion of fat in the intestine. It's caused by deficiency of the following enzyme.
All right, so here it is a simple question which we are not going to waste much time on big screen. So in the stomach, we produce what? Pepsin, ACL, and other substance, digestive juice like renin, which helps in the digestion of proteins, and renin in the formation of casein type, and ACL also will cause what? Sterility of the food that is coming there. But when the food gets here, we have a lot of what? Pancreatic enzymes which are being released here. An example of such pancreatic enzyme is lipase, pancreatic lipase. What does it do? It breaks down the fat that, the lipid that came there, okay? So it breaks it down. But before it breaks it down, it first needs bile to what? Emulsify that lipid or the fatty food, and then it can actively break them down to what? Glycerol. Okay, so lipase here will break down fat. We've already spoken about this thing. So pancreatic lipase, okay? It will break down lipid into what? Glycerol and free fatty acids. Okay, so when you are not able to break down this lipid into glycerol and fatty acid, then it means that these, because these glycerol and fatty acid are free fatty acids, are the forms that the body can absorb. Okay, so they will be absorbed, and then through your lacteals, it will pass through your lymphatics, and eventually will be dropped into your superior vena cava, and it will be part of your circulatory system. But if you are not able to break this lipid down into glycerol and fatty acid, this lipid will not be absorbed, and it will go out as part of your feces. And when you are having feces containing a lot of lipid, we call it what? Steatorrhea. Okay? And this steatorrhea is a very offensive type of stool, which is very difficult to flush. Okay? So in someone who had their pancreas removed, okay, all the pancreatic juice or the pancreatic enzymes, which we have what? Lipase as part of it, will not be produced. Okay? Other ones that we have are pancreatic amylase, which will break down what? Polysaccharides. And we also have what? Trypsin and chymotrypsin, which will break down what? Proteins. Okay? So the answer is what? Pancreatic lipase. Let's move on to the next question. Okay, so after partial pancreatic resection, the patient develops steatorrhea, which indicates disturbed digestion of fat in the intestines. It is caused by deficiency of the following enzyme, and the answer is going to be C, lipase. Okay, let's move on. Okay, so Pilar, can you please read question number 8 for us?
Number 8, a 21-year-old patient complains of weakness and elevated temperature up to 38 to 40 degrees Celsius. Sorry. Let me start fresh. A 21-year-old patient complains of weakness and elevated temperature up to 38 to 40 degrees Celsius. Objectively, the liver and spleen are enlarged. In blood, hemoglobin is 100 grams per liter. Erythrocytes 2.9, leukocytes 4.4. platelets 48, segmented neutrophils 17%, lymphocytes 15%, blast cells 68%. All cytochemical reactions of blast cells are negative. What hematologic conclusion can be made?
All right. So the question has given us some parameters. Okay. Look at it. They said that HB is 100 grams per liter, which is low. Erythrocyte level should normally, the HB level should normally be between 12 to 14 in females and 13 or 14 to 16 in males. Okay, so it is all in terms of gram per liter. We should say 120 to 140 in females, 130 to 160 in males. That is the normal range. So in this case, this one is what? Moderately low. Then we have, or mildly low, we should say. So, and we have erythrocyte, which in males should be around, the count should be around 4.7 to 5.5, and in females should be around 3.8 to 4.8. But here it is 2.9 and it is low. Leukocyte level is normal because the normal range of leukocytes should be between 4 to 10 or 4 to 12 in some books. And platelet count is low. Platelets should be around 150, 180 to 300 or 350. Okay. Segmented neutrophils here should be the adult form of neutrophils and it should be around 68%. Okay. And lymphocytes should be around 25 to 30%. Blast cells should not be seen. Blast cells should not be seen in the blood of a normal person. Okay, all the cytochemical reactions of blast cells are negative. So it means that this particular blast cells, when they even put it under the microscope, they cannot see any characteristic of it which you can say that it belongs to this particular lineage or that particular lineage. So let's come to the board and let me explain something here for you to understand. So in the bone marrow, we have a stem cell which we call the pluripotential stem cell, okay? And in the pluripotential stem cell, they can what? Differentiate into what we call multipotential stem cells. Now, this multipotential stem cells here too is a blast cell, okay? However, when they are at this stage, they exhibit some characteristics, okay, that will determine whether they will be what? Myeloid or what? Lymphoid cells, okay? So they are the progenitor blast cells for lymphoid or myeloid cells, right? So the progenitor cells here, probably for lymphoid and this one for myeloid, right? So with the lymphoid progenitor cells, they will develop into the lymphoblast, okay? And the lymphoblast, we have two, T lymphoblast and B lymphoblast, okay? They will differentiate. But remember I said here, there are some cytochemical characteristics. It means that in their cytoplasm, there are some cell inclusions, okay? There are some characteristics of their nucleus that differentiate the myeloblast from the lymphoblast, okay? However, this myeloblast here will give us the colony forming units, okay? So colony forming units for, let's say, megakaryocytes, okay? So they'll give us colony forming units for megakaryocytes, which will eventually become what? Our platelets, right? Then they'll give us colony forming units for what? Let's say erythrocytes, which will lead to the production of our red blood cells. And they also give us colony forming units for our granulocytes and agranulocytes, okay? So the granulocytes here, so we see FU, granulocytes, will lead to the production of our neutrophils, eosinophils, and basophils, right? And the agranulocytes here will lead to the production of our monocytes. And these monocytes can differentiate to give us our macrophages, right? Now, what I said was that at this level, normally most of the cancers of the blood start at this level, at the blast level, at the multi-potential level, okay? Or they can start at the level of what? When they have differentiated to some actual progenitor cells like the T lymphoblast. Okay, so this one will be T lymphoblast. And this one will be what? B lymphoblast, right? So what it means is that even this progenitor cell, which will lead to the production of T or B lymphoblast, has some characteristics that you can use to differentiate it from the myeloblast, right? So even if the cancer occurs at this level, it means that they are undergoing massive mitosis at the level of the blast, which normally that is what happens, okay? But the characteristics of the blast cell, as whether it can differentiate to any of the intermediate cells, will determine whether it is what? A myeloid or a lymphoid, right? At the same time, whether it can also differentiate up to some level of the intermediate will also determine whether it is the chronic myeloid or the chronic lymphoid, or it is acute myeloid or the acute lymphoid. We've spoken extensively about that, but that is not what we are talking about now. But when they say that the blood cell count has increased, which I told you that the blood cell ideally shouldn't be in our blood. The blood cells should be in our bone marrow, okay? The blood cells should be in our bone marrow. They should differentiate into immunocompetent cells, or it should differentiate into what? What we call the erythrocyte, okay? Then we can say that now these cells have differentiated into mature forms, so now they should leave the bone marrow and go into the blood to perform their function. If the blood cells are developing at a faster rate at the bone marrow level, but they are not able to differentiate it from the lymphoid or the myeloid blood cells, then we say that blood cells have negative cytochemical reaction. Okay? So when you cannot differentiate it from the myeloid blood cells or the lymphoid blood cell, we say they have what? Negative cytochemical reaction, because you have to do the cytochemistry in order to know that this one is going to eventually become a lymphoid or what? A myeloid cell. But if you cannot differentiate it, then the cytochemistry will be negative. When the cytochemistry is negative, we call it what? Undifferentiated. Undifferentiated. And because there is what? Increase in production of these blood cells, it is what we call, and they are what? Unregulated, uncontrolled, and unwanted growth of the blood cells. They are called cancers. Okay? And that cancer here of the bone marrow, we normally refer to it as what? Leukemia. Okay, so when we cannot differentiate it from the myeloid or the lymphoid progenitor cells, we call them undifferentiated leukemia. Okay, now they are growing at a faster rate and they are not differentiating to any of the cells here, right? So what is going to happen is that they will suppress the production of all the cells here. You understand? That is why all the cells there, the neutrophils count is low, the lymphocyte count is low, the red blood cell count is low, even the platelet too is low. You understand? So when it happens like that, when you see that all the mature forms are low, and at the same time they are making mention of negative cytochemical reactions, then you should know that it is an undifferentiated leukemia. Does anybody have any question? Okay. So someone may ask, why is the total white blood cell count normal? Because before the beginning of the disease, the person had already produced some white blood cells, and those white blood cells are already in the marginal flow. Okay, and at a point in time, they will jump into the axial flow. So what we mean by marginal and axial flow is this. This is your blood vessel. When you are taking blood from the vein, there is some blood which are moving in the center, and those ones are called axial flow. So in the center, when blood is moving in the center, we call it axial. But there are some red blood cells which are on the surfaces of the endothelial cells, and they are not actually flowing too, and those ones are called marginal flow. They flow but very slowly. And when you are taking a blood sample, you only get it from the axial flow, not from the marginal flow. Okay? Okay. So let's read the question again and answer it, and then let's move on. A 21-year-old patient complains of weakness and elevated temperature up to 38.49 because this patient does not have any strong immunity again, so he will be prone to infection. That is why here there is a lot of infection and then increase in body temperature. Objectively, the liver and the spleen are enlarged. Why? Because these blood cells, after they start growing abundantly, they don't stay in the bone marrow alone. They jump into the blood. That is why now when you take the blood sample, you see that their count has increased. Ideally, they shouldn't have gone into the blood. So when they jump into the blood, where do they go to? They get to other tissues and get stuck there, and they keep on growing. They keep on dividing. And whilst they keep on dividing, they cause enlargement of those tissues. It means that the cancer has spread, right? In the blood, HB is 100, which is low. Erythrocyte is 2.9, which is low. Leukocyte is 4.4, which is normal, but not because we have normal listening. And we have platelet 48, which is low. Segmented neutrophils is also low. We have lymphocyte 15%, which is also low. But blood cells are what? 68. All cytochemical reaction of blood cells are negative, and that is where you get your clue from. When they said all cytochemical reaction of blood cells are negative, then think of what? Undifferentiated leukemia. And that is the answer. Does anybody have any question? If not, let's move on. All right. Lydia, can you please read the question number 9 for us? Is Lydia around? All right, so Samuel, can you please read question number 9 for us?
Hello, yeah, I'm around.
Okay, so read the question.
A 60-year-old, man, spontaneous rib fracture. X-ray shows multiple sulfide foci of bilateral costal osteoporosis. Biopsy material obtained from the place of the fracture showed uniform proliferation of lymphocytic plasmacytic cells with signs of cellular atypia. Name this disease.
All right, so please a bigger screen here and let me show something here and then project it. So remember we said that the progenitor cell here, the stem cell here is pluripotential, which will divide into some progenitor cells. These progenitor cells here is the B lymphoblast, right? The B lymphoblast here should differentiate into what we call the B lymphocyte, right? And when you develop it into B lymphocytes, okay, when you develop it, when it differentiates to B lymphocytes, during an immunological stimulation, what happens is that this B lymphocyte is again differentiated into what we call plasma cells. Okay? And these plasma cells will now lead to the production of what? Antibodies. Right? Now look at something. Sometimes, okay, sometimes there is differentiation of some B lymphocytes that will lead to the production or the formation of some plasma cells or plasmocytes. And these plasma cells will what? Be dividing at an abnormal rate. Or there can be an abnormal differentiation of B lymphocyte to plasma cells to a lot of the plasma cells, and they will start producing a lot of antibodies. So either a B lymphocyte is differentiating into the plasma cells, or the plasma cells there is also undergoing some division, and it has led to the production of a lot of antibodies. Okay, look, because they were differentiated to plasma cells not based on immunological response, so these antibodies here are not antibodies that can fight against some specific infection. So that differentiation or that division that is occurring here wasn't stimulated by any immunological response. It occurred spontaneously, and it's a form of cancer. Okay? So when only one plasma cell has been identified, okay, one focus of plasma cells have been identified to be producing abnormal forms of what? Antibodies, okay? Abnormal antibodies. Then we call it what? Plasmacytoma. Okay? But when we have multiples of plasma cells secreting or producing a lot of abnormal antibodies, then we call it what? Multiple myeloma. Okay? Call it multiple myeloma. Okay? Or they sometimes call it what? Myelomatosis. Why am I writing all these names? Because sometimes in Krok, they will bring multiple myeloma or they will bring myelomatosis. It's the same thing. Okay? So, when this thing is happening, because it wasn't by immunological response, normally they are occurring in the bone marrow. Okay? They are still occurring in the bone marrow. And when it is occurring in the bone marrow, they increase in size. Okay, the number will increase, and what will happen? They start damaging the bone marrow. Okay, so one of the commonest symptoms in multiple myeloma is bone pain or pain in the bone, right? Now, when they start destroying the bone there, what will be released? Remember, bone is having what? Osteocytes, and they have a ground substance which is called osteoid, and they have the position of what? Calcium carbonate and stuff like that, right? Into it, and they together form the bone, right? So when you break down the bone, what are you releasing? Because this osteoid is made up of some ground substance like glycosaminoglycans, okay, like chondroitin sulfate and stuff like that. And they can be broken down to other useful substances. But when you break down this, you release calcium into the blood. So you realize that because of that, a lot of calcium will be inside the person's blood. Right. Another thing is that These antibodies that were produced, okay, they are abnormal forms, okay, and in fact, these plasma cells produce such abnormal antibodies or proteins that we call paraproteins, okay? Call it paraproteins. Or sometimes they call it Benz-Jones. Okay, Benz-Jones proteins. So when you look at it, you realize that there are a lot of abnormal proteins which looks like antibodies, but they are not antibodies. They are called paraproteins or Benz-Jones proteins. And these Benz-Jones proteins cannot perform the function of antibodies. So infections will be high. Okay? Increase in infections. Now the plasma cells too are able to produce some misfolded proteins, right? And we call those proteins amyloid proteins. Okay? You know these amyloid proteins, you can use Congo red to check it. Okay, Congo red. Congo red staining will let you know that the person is having amyloid. So in this patient, you realize that they can have bone pain, they can have high calcium level in blood, okay? High calcium level in blood. And they can have some abnormal antibodies, which are also proteins, and we call it paraproteins, or they call it Benz-Jones proteins. And because these antibodies cannot perform any immunological function, but because they are produced at a faster rate and they have occupied the bone marrow, they are suppressing the normal production of antibodies and immunological cells, which should be giving us protection against invading organisms. So because they've suppressed those ones, the infection rates in this person will increase. And these plasma cells are able to produce some misfolded proteins, also called amyloid proteins. And because they are producing amyloid proteins, this patient can have what? Some kind of renal failure due to what? Amyloid. Okay, so we have renal amyloidosis. Okay, so does anybody have any question here? So look at it. That pluripotential cell differentiated into the lymphocyte progenitor cells. And that lymphocyte progenitor cells develop into what? T lymphoblast and B lymphoblast. These B lymphoblasts will differentiate into B lymphocytes. This B lymphocyte here ideally should convert to what? Plasma cells to produce antibodies to fight against infection. However, there are some kind of cancers which there are a lot of these B lymphocytes differentiating into plasma cells and then producing abnormal proteins without immunological response. I mean, stimulation, immunological stimulation. So when that happens and there is only one cell, plasma cell, causing the excess production of abnormal antibodies, we call it plasmacytoma. When there are multiple of plasma cells causing the same reaction, we call it multiple myeloma or myelomatosis. When someone has myelomatosis, the patient will experience bone pain. There will be what? Dissolution of the bones, and that will lead to increased calcium in the blood. There will be production of abnormal proteins, which is called paraproteins, or they also call it Benz-Jones. There will be increase in infection because the antibodies produced here are not normal and they cannot perform an immunological function. And there can be the production of amyloid proteins, okay? And in that case, another thing will happen because all the other cells are being suppressed. The patient will also experience what? Anemia, right? Or red blood cell production to go down. Does anybody have any question here? All right. So project the question, let's answer it and let's move on. All right. So a 60-year-old man's spontaneous rib fracture. X-ray shows multiple separate foci of bilateral costal osteoporosis. That is what I told you, the dissolution. Biopsy material obtained from the place of the fracture shows uniform proliferation of lymphocytic plasmacytic cells. So those are the plasma cells we are talking about. With signs of what? Cellular atypia. So when they say cellular atypia here, it means they are talking about a cancerous type of condition. Name this disease, and the answer is going to be what? Multiple myeloma. Let's move on to the next question. Okay, so Amy, can you please read question number 10 for us?
In an experiment, after a prolonged electrical stimulation of the peripheral vagus, a brief cardiac arrest occurred in the subject. What ion mechanisms in the cardiac cells cause this effect?
All right, so bigger screen, and let's do this one first, and let's talk about it. So cardiac cell, right? So on the heart, last time I spoke about this thing that the heart is having SA node, AV node, bundle fiber. Then we have the Purkinje fibers, and we also have the contractile fibers. And we said that this SA node, this AV node, these bundle fibers, and the contractile fibers are being supplied by what? Sympathetic, having sympathetic supply. But the AV node here and the SA node and the AV node here have what? Parasympathetic supply. Specifically, the parasympathetic fiber bringing it is the vagus nerve. Okay? So we have the sympathetic supplying 4 parts, and vagus, which is parasympathetic, supplying only the AV and the SA node. Sorry, SA and AV node. Okay? So let's see how the parasympathetic fiber. And remember that we said that when sympathetic activation occurs, there is increase in conduction, there is increase in impulse generation, there is increase in conduction, there is increase in excitability, and there is also increase in contraction. So impulse generation will be what? Chronotropic. The conduction through the AV node will be what? Dromotropic. The bathmotropic will be the increase in excitability, and the increase in contraction here will be what? Inotropic effects. That is for positive inotropic, positive chromotropic, positive bathmotropic, and positive what? Chronotropic effect when sympathetic fibers are stimulated. But when you stimulate the vagus, because it is supplying only the SA node and the AV node, SA node generate the impulse, so they'll do what? Negative chronotropic effect. AV node will do the conduction, and that will give us what? Negative what? Dromotropic effect. Let's see how it does that negativity. So imagine this is the SA or AV node, right? Remember, parasympathetic releases what? Acetylcholine, right? And on the heart, we have, is it M3? M3 receptor, right? Or is it M1? M1 is in the stomach. M3 is in the is on the heart. So we have receptors for acetylcholine called M3 on the AV node. So let's say AV node or SA node, right? So look at what is happening. When vagus is stimulated, I mean when parasympathetic is stimulated, they release acetylcholine here to their receptor. And this receptor is M3 receptor, muscarinic 3 receptor. They will undergo what we call G inhibitory, right? 1, 2, 3, 4, 5, 6, 7. So there are also 7 pass receptor, okay, which is having an inner proteins bound to each other. That's the beta and the gamma and the alpha, right? Now look at what they do. All right. First of all, I'll explain something here. Remember the type of inhibitions we spoke about. This vagus nerve, when it is coming to stimulate the the SA or the AV node, you will give a branch to cause what we call presynaptic inhibition. So they will inhibit their neighboring fiber, which is the sympathetic fiber. So here they will release GABA onto them, or even if they don't release GABA, they are going to release the same acetylcholine. And that acetylcholine is going to inhibit this sympathetic fiber. Okay, that acetylcholine is going to inhibit these sympathetic fibers. So it means they render the sympathetic fibers useless first. Okay, and they continue to release acetylcholine onto the AV and the SA node. And when they release that acetylcholine to bind to their M3 receptors here, this is what is going to happen. Remember that when SA node is stimulated by sympathetic, we will have what? We will have adrenalyl cyclase converting ATP to what? CAMP, and CAMP will in turn activate what? So let me just explain that aspect here first. Then you understand what is going on here. So when sympathetic activity is stimulated, this is what is going to happen. Sympathetic is having what? Beta what? 1 receptor on the AV and SA node. They are also going through what we call G stimulatory. Okay? This one is going through G inhibitory. All right? This one is going through G inhibitory. This one is going, so this one is sympathetic. And this one is parasympathetic. Now look at what sympathetic will do. So for you to generate impulse at a faster rate or to conduct the impulse, you need to allow positivity to come in, right? We said that when positive ions come inside the cell, then the cell can be excited and action potential can be generated, right? So we need to find a way of increasing the positivity inside the cell, right? So when adrenaline binds to 8-beta-1 receptor here, we call this one beta adrenergic receptor because it binds to what? Adrenaline. When sympathetic fiber is stimulated, they release adrenaline here on the SA node. And on the SA node, it is having some receptor called beta-1 receptor, adrenergic receptor. And it is a type of receptor which binds to adrenaline. That is why we call it adrenergic. Okay, so when they bind to the receptor is having an outside cellular domain and the inner cellular domain. The inner cellular domain is having beta, gamma proteins, and alpha proteins, which are held together. They are held together when there is what? GDP. When stimulation occurs, GDP will be converted to GTP, and GTP will stimulate the alpha part here to move. When they move, they bind to some cellular membrane or protein, which we call adrenalyl cyclase. Okay, so alpha will move here, and they will bind to adrenalyl cyclase. And adrenalyl cyclase will in turn convert ATP here, okay, will be converted to what? CAMP, right? And this CAMP will go and bind to some enzyme called protein kinase A. So when CAMP binds to protein kinase A, they activate it. And when they activate it, what does it do? It adds phosphate group to ion channels and enzymes. Okay? Look, when you phosphorylate an ion channel or an enzyme, it means you have activated it in terms of this. Okay? Not always is it like that. Okay, but in terms of cardiac activity, when you phosphorylate ion channels, you have activated it. So, and some enzymes too can be activated though. So when pKa is activated by CAMP, pKa will now phosphorylate. It will donate a phosphate group here. Okay, and what does it do? It causes this ion channel to open to allow more ions to come in. So in the SA node, what ions will cause the influx? Normally in the SA node, the small ions that will come in is the SA node. Sodium. Sodium will now move from the extracellular chamber to the intracellular chamber. Okay, and what will happen? It will cause impulse contraction, because here it is not sodium which generates it, it is calcium in the SA node. Put it in your mind. Here, action potential is generated by calcium, not sodium. Okay, so sodium will come in, then shift the resting membrane potential towards what? Threshold, and calcium voltage gated channels will open, more calciums will come in, and action potential will be generated, right? But you see, it is more complicated than that, because the SA node has its own what? Pacemaker. So it has some funny channels which already allow some sodium to rush in and trickle in a bit. But when you activate sympathetic fiber, it increases the speed at which sodium goes inside, right? And now action potential will be generated within some shortest possible time. So that is how the G-stimulatory works. Now, ideally, we have some enzyme called phosphodiesterase, okay, which will break down CAMP, and then it will stop the reaction, right? Now look at something. Then the alpha will come back to 8 parts, and GDP is already formed. Now in the G inhibitory, this is what is going to happen. The same reaction will occur. GDP will be converted to what? GTP. And alpha will move here. But here, when alpha moves to the adenylyl cyclase, it inhibits it. Remember here, it stimulated adenylyl cyclase, but here it will inhibit it, right? It will inhibit adenylyl cyclase in the G inhibitory pathway, which receptor, when stimulated, will cause G inhibitory. So that will tell you this one is not M3, this one is M2. Okay, so the correction, the SA node and the AB node have M2 receptors, not M3, right? It has M2 receptors. I first said M3, it's a mistake. It's M2. So M2 will cause G inhibitory. How? When parasympathetic fiber, which is vagus nerve, 10th cranial nerve, okay, is stimulated, it releases acetylcholine to its M2 receptor on the SA or the AB node. Then GDP is converted to GTP. Alpha will move from beta and gamma and bind to adenylyl cyclase. And when they bind to adenylyl cyclase, they inhibit it. So adenylyl cyclase cannot convert ATP to GTP, ATP to CAMP, like how it occurred in the G-stimulatory pathway. So it has inhibited it here. That is what is making it what? Inhibitory. You know one thing that is going to happen. So when there is no CAMP, pKa cannot be activated. There can be what? Opening of sodium channels, right? Again, what is going to happen is that you see this gamma and beta. You realize that in the stimulatory pathway, they didn't move. They remained there. They were faithful to their inner domain. But in the G inhibitory pathway, they will move. When they move, they bind what? Potassium channels, and they will allow potassium to leave the cell. Remember, we said whenever potassium leaves the cell, the inside of the cell becomes what? Hyperpolarized, right? Hyperpolarized. We said two things. When you want the cell to become hyperpolarized, you either let potassium leave the cell or you introduce what? Chloride ions, which are what? Negative ions. Okay, but in this scenario, potassium will leave the cell. So we call it what? Potassium efflux. Right? And when cell become hyperpolarized, it means that it will take a very long time before you can generate an impulse in this cell. It means it has been inhibited. It means that impulse generation will take a long time. Impulse conduction will also take a long time. Do you understand it? So let's read the question again. And remember we said that, first of all, when the vagus is stimulated, it will first inhibit the sympathetic fibers through the same pathway, okay? Then you again inhibit their SA node and the AV node also. And now the heart rate will go down because the impulse conduction has gone down. Impulse generation has also gone down, right? All right, so let's move on. Let's read the question and then answer it and move on. In an experiment after a prolonged electrical stimulation of the peripheral nerve vagus, a brief cardiac arrest occurred in the subject. So you now understand why the cardiac arrest occurred, because there is hyperpolarization, there is inhibition. What ion mechanism is the cardiac cell caused this effect? And we explained that there should be potassium leaving the cell, and we call it what? Potassium efflux. So whenever there is increase in potassium efflux, okay, whenever there is increase in potassium efflux, hyperpolarization will occur, and the cell will be what? Inhibited. So the answer is going to be what? Increased potassium efflux. That is B. Does anybody have any question? Okay, let's move on to the next question, please. All right, so Fatuma, can you please read question number 11 for us?
Healthy parents gave birth to a son with phenylketonuria.
Mm-hmm.
The child presents with normal development due to a special diet. What type of variability is associated with the convalescence of the child?
All right. All right, so first of all, we will talk about what phenylketonuria is, not into detail, but just something small. Or I think there is another question on it. So let's just talk into details, and then when we get to that question, we'll just skip much explanation. All right, okay? Then we'll talk about what convalescence means, and we'll talk about what genetic variability is, and then we'll explain what modification variability is, okay? So, when we talk about phenylketonuria, okay, ideally what is happening is that all right, so we have an amino acid called phenylalanine, right? This particular amino acid is an essential amino acid, right? So it means we take it from, we can only get it when we eat. So we can get it from the meals that we eat, okay? Now, when it gets into our body, it can be used for so many things, right? And an example of the things that it can be used for is to first convert it to another form of amino acid, which is called tyrosine. Okay, so we have to convert phenylalanine to tyrosine. And what tyrosine can be used for is that tyrosine, one, can be converted into melanin, right? Okay, and tyrosine here can be converted to what we call the L-dopa, and from L-dopa to dopamine, and you can get what? Dopamine as adrenaline and noradrenaline. So we can get some neurotransmitters, right? Okay, so yes, these are some of the functions of tyrosine. And we can also, so these neurotransmitters are called catecholamines, right? Catecholamines. And we can get some proteins, okay, cellular proteins from it, right? Now, before you can convert phenylalanine to tyrosine, you need an enzyme called the alanine hydroxylase, okay? Hydroxylase. Please keep this enzyme in mind. It's very important. It comes in the Krok almost all the time. So for you to convert phenylalanine to tyrosine, that reaction is catalyzed by phenylalanine hydroxylase, right? However, there are some people who are born defective of the genes. Okay, when we talk about genes, we are talking about some DNA sequence, right? You have some DNA in your body like that, right? In your nucleus, right? And it is having some nitrogenous, or what we call the complementary pairs, right? Nitrogenous bases and complementary pairs. Sometimes, when you want to produce proteins, right? This DNA has to open up, right? When it opens up, then there will be formation. When you want to produce a protein, then there will be what we call transcription. Transcription here will lead to the production of an RNA, mRNA, okay? Can be tRNA, can be rRNA, right? So when you want to produce a protein, there is a process called transcription. And that particular protein which has to be produced, there's going to be a template of it that has to be read from the DNA. There is a sequence for that protein production, right? So that sequence of nucleotides, that sequence of nucleotides on a DNA, okay, this is the DNA, okay, that can code for the production of a protein is what we call gene, right? Right? So the gene is that sequence of nucleotide in the DNA that when we produce an mRNA from, we can read the coding here on the mRNA to produce a protein, right? That particular sequence is called a gene, right? So it means this mRNA will come from the DNA, the gene part, right? And then it will be used to produce some proteins, all right? So these proteins, example of it is this enzyme, okay? This enzyme called phenylalanine hydroxylase, right? So when someone is born with defects here, okay, defects in that gene, that DNA sequence that has to code for this particular mRNA to be used to convert, to produce this protein or this enzyme called phenylalanine hydroxylase. The person does not have it. In fact, this person does not have it on any of it, or on any of his or her complementary pair of chromosomes. Why? Because the father was defective and the mother too was defective. So see, we have mother's chromosome, okay, 2, and we have father's chromosomes which have complementary pairs, right? The mother's chromosome here is having what? 23 pairs of chromosomes. The father's chromosome is also having 23 pairs of chromosomes. However, they will all donate what? Only half of those chromosomes. So they will donate 23 chromosomes, which is not paired. The mother will donate 23, the father too will donate 23, and together they will come and form the baby, right? However, let's just imagine the mother was having normal chromosome, one normal chromosome, but one abnormal one, right? And the father too was having one normal chromosome, one abnormal one, right? And then they give birth by donating all the abnormal ones, okay? So let me make it this way. This chromosome is defective, right? This chromosome. So it means these chromosomes, which are in blue color, they are the chromosomes that does not have the gene that code for the protein phenylalanine hydroxylase. So when the mother donates that defective gene, and the father also donates that defective gene, then the baby can suffer from the disease. It means that the baby has inherited both defective genes from the parents. The parents were carriers. Because they had one normal gene, they were still able to code for that phenylalanine hydroxylase. But because when they were donating their chromosomes, they donated the abnormal ones to the child does not have any healthy gene which can code for this phenylalanine hydroxylase. When this scenario occurs in genetics and the person suffers from that disease, then we say the person is suffering from. And when it is occurring in autosomes, remember the first 22 are autosomals and the last 23rd chromosomes are what? Sex chromosomes. So when they are occurring in any of those 22, we say the person is having what? Autosomal recessive disease. Okay? Autosomal recessive. Why? Because the baby has inherited all the abnormal genes which were recessive to the normal ones, right? Why are they recessive? Because in the presence of the normal gene, they are not expressing themselves. So they are called recessive. But when the two of them, which were actually recessive in the presence of normal genes, come together, they express themselves in the phenotypic aspect, like in the physical appearance, okay? So this condition called phenylketonuria, okay, is an autosomal recessive condition which has led to the non-production of what? Phenylalanine hydroxylase. So those people who are having phenylketonuria don't produce what? Phenylalanine hydroxylase. Now, if you don't produce phenylalanine hydroxylase, do you think you can produce tyrosine from phenylalanine? No. However, you can still get tyrosine because we eat a lot of food which have this amino acid called tyrosine, right? Now, when it happens like that, it means that whatever food that you are going to eat and is still in the form of phenylalanine, it cannot be used for anything, right? So it will accumulate in your body. Whenever it is accumulated in your body, it is converted into other forms. You can have what? Phenylactate. Okay? Phenylactate. You can have phenylacetate. Okay? And you can also have what you call phenylpyruvate. Okay? Do you understand it? Now see, when you don't have phenylalanine hydroxylase, it means you cannot convert phenylalanine to tyrosine, right? So when that happens, it means that this phenylalanine will tend to accumulate in our body. And when it is in our body, it is converted to other forms, which are not very important to our body. But it's converted to a form that can be excreted from the body, right? And that form, we have phenylactate, phenylacetate, and phenylpyruvate. Now, these forms can appear in your urine and in your blood. This phenylacetate here is a ketone, or we also call it phenylketone. phenyl what? Phenylketone, right? So because this phenyl acetate can appear in your urine, then they said the condition should be called phenylketonuria. Does anybody have any difficulty in understanding what we just explained? All right. So because the person is going to accumulate this substance and it can appear in their urine, the urine will have some kind of odor, which we call it mousy smell. Okay, mousy smell. And because they are not going to convert to tyrosine, do you think we can have enough melanin? Yes, we will, but it will not be enough, and it will lead to what? Hypopigmentation of the skin. And because we are not going to produce enough catecholamines, our central nervous will also be disturbed. So this child will have what? Mousy smell urine, and they will have what? Hypopigmentation of the skin, and central nervous system development will be an issue. Okay, now look at something. The treatment of this condition here is that, remember we said that this phenylalanine is an essential amino acid. We can only get it in our body when we eat some food which contains phenylalanine, right? But what if we stop taking that food, a food which contains phenylalanine? It means that there will be no phenylalanine to cause all these reactions. Okay, so that is what we call modification of food, right? Modification of what? Diet, or modification of food. We call it what? Modification of diet. Now let me explain exactly why the answer is going to be what it is. Now, the first word that you should understand is convalescence. When we say convalescence, it's the time spent recovering from illness or a medical treatment. Okay, so the period between the time that you suffered from the condition and becoming healed, we call it convalescent period, right? And you see, in our genes, there is something we call genetic variability. So in genetic variability, we have, it is the measure of the tendency of an individual genotype to survive in a population, right? Through assortment, or you remember those things, like if your genes are not very strong, you are eliminated, and the ones with strong genes are kept, right? Now, this type of variability can occur. So, for instance, I'm an African guy, and I'm not used to the cold weather here, right? So when I came here for the first time, I had to put on a lot of clothing, right? But the Ukrainian who was born and bred here will also put a lot of clothing, although, but not as much as mine, because genetically there has been some modification that can lead to the excess production of what? Tyrosine. And that will lead to production of heat in their body. But me, in my country, there is only sun and sand. So I've not experienced such type of cold. So genetically, there hasn't been any modification or any genetic alteration to cause the release of tyrosine in that excess amount. When it happens like that in my country, then you are suffering from thyrotoxicosis. Okay? So when I came here, I had to modify the way I dress in order to conserve some heat, right? So that kind of modification or that kind of variability to make me survive is called modification variability. That one, you are just only changing the phenotypic, the physical aspects of the organism to make sure that the organism also survives. But those ones with the genotypic ones, like I said, the Ukrainian, they are already born with some alteration in their genes that will lead to excess production of tyrosine that will make them to be able to withstand the cold weather better. But for me, when I want to survive the cold weather, I have to put on a lot of clothing. So in genetic variability, we measure the tendency of an individual genotype in a population to vary from one another. So you see, that is the variation, okay? Their genotype is different from mine, okay? But how are we all going to survive it? Then for them, their gene has some specific variation, which I don't have. But if I want to experience the same thing that they have naturally, or they have inherited from their parents, then I have to do some physical modifications, right? So in someone who is having phenylketonuria, okay, it is just like the person is, in a healthy person, has the genetic variation or the genotypic variation to be able to produce the phenylalanine hydrolysis. Okay, so because of that, they don't need to change anything physically, okay, to be able to convert phenylalanine to tyrosine. But for those people who don't have that genetic material or the gene which codes for this phenylalanine hydrolysis, if they want to still survive, then they have to modify their physical activity in order to be able to what? Have a normal living. And that modification is what we call the phenotypic or modification variability. So in that case, we call it what? Modification variability. Does anybody have any question here? All right. So modification variability is also called phenotypic variability. Okay. I'm just writing phenotypic. Why? Because they might change it from modification variability to what? Phenotypic variability. Okay. So please project the question and let's move on. Let's answer it and move on. Quick. Have some few minutes to close. Okay, so let's move on to question number 12. In an experiment, a dog was administered a certain hormone, which resulted in increased glomerular filtration due to dilatation of the afferent glomerular arteriole and decreased reabsorption of sodium ions and water in the nephron tubules. What hormone was administered? Now, bigger screen, please, and let me just explain this one quickly, and we'll move on. So, whenever there is increase in blood volume, and whenever there is increase in so this is our heart, right? Whenever there is increase in blood volume, how? Probably the heart is not able to pump the blood very well. So the blood cannot leave, right? It cannot leave into general circulation. So when the blood is staying in the atria, okay, they distend the atria. Or whenever there is increase in venous returns, they stretch the atrium of the vessel. Now, in the heart, we have special cardiac cells. We have the ones that produce hormones, okay? So we call them endocrine cells. We have the one that generate excitability, okay? Like the SA node, AB node, Purkinje fiber, bundle fibers, okay? So they are excitable cells. And we have the ones excitable. And we have the ones that are responsible for contraction, and they call contractile cells, right? Like the ventricular cells or the atrial cells, right? So they are called contractile cells. Now, these the endocrine cells of the cardiac muscles, they have stretch receptors. Okay, so whenever their stretch receptors are stimulated by this tension of the atria, they release a hormone called atrial natriuretic hormone or atrial natriuretic peptide. So a lot of times, people who are suffering from heart failure have this scenario occurring because there is a lot of venous return, but the left ventricle cannot pump it forward, right? So there is always stretch in the atrium, right? And in that case, there is a lot of release of atrial natriuretic hormone. Now, this atrial natriuretic hormone has a lot of receptors, right? And some of these receptors, once stimulated, they activate what we call the guanylyl cyclase pathway. In a nutshell, what the guanylyl cyclase pathway is going to do is that it is going to cause smooth muscle relaxation in the afferent arterioles, mostly. Okay? And again, they inhibit the activity of angiotensin 2. What will angiotensin 2 do? Angiotensin 2 will go to the kidney, specifically where the adrenals of the kidney, and stimulate the glomerular cells to produce what? Aldosterone. Right? And aldosterone will increase the reabsorption of sodium and water and increase the excretion of potassium. You know the beautiful thing about AMP again? AMP will directly also inhibit the activity of aldosterone also. Okay, so because of time, I don't want to discuss about the details, but know that AMP will cause what? Vasodilation by what? Causing smooth muscle relaxation, right? Muscle relaxation. And they also cause increase in excretion of sodium and water by what? It inhibits what? Angiotensin 2. Okay? And also inhibiting what? Aldosterone. And you know another beautiful thing, they even block sodium channels, okay? They block what? They block sodium channels in the distal convoluted tubules. And the ascending thick limb of the loop of Henle. You understand? So by doing all these activities, they're able to allow, you see, aldosterone was supposed to have allowed sodium to have been reabsorbed and water will follow and potassium will go out, right? But when you release atrial natriuretic hormones, they will what? Inhibit the activity of aldosterone. And the activity of aldosterone will not be there. So now sodium will be excreted, water will also be excreted. Potassium will be what? Retained. Block sodium channels, not only in the distal convoluted tubule, but also the ascending limb of loop of Henle. So that those sodium which were supposed to have been reabsorbed by the endothelial sodium channels, which they call ENaC, they are also what? Inhibited. So that sodium is not reabsorbed. So they have a multiple of actions. And whenever we meet any questions again, and we have enough time, we'll go into details. Okay, so let's look at the answer. And the answer is going to be atrial natriuretic peptide. Let's look at the answer first before we move on. So in an experiment, a dog was administered a hormone which resulted in increased glomerular filtration due to dilation of the afferent glomerular arteriole and decreased reabsorption of sodium, iron, and water in the nephron tubules. What hormone was administered? And the answer is going to be what? Atrial natriuretic hormone. Okay. Does anybody have any question? If no, let's move on. All right. So a patient has an open facial wound with undermined edges, necrosis, tissue necrosis with gradual developing partial gangrene that nearly reaches the bone tissue is observed. On close examination, the wound contains larvae, live larvae. The patient is diagnosed with tissue myiasis. What diphtheria larvae are causative agents in this disease. So we are going to project some picture here. I'll send the pictures. No, but that's what we show you in the pictures. All right, so we are having some technical difficulties, but here you see that there is a fly called the Wolfachia magnifica. Okay, these are like house flies, but they are not house flies. They are bigger than house flies. Okay, and we are trying to show you a picture of that. So just a moment, just a moment. All right. So what this fly does is that whenever they land, so we'll show you some life cycle of the fly. They are normally found in areas where there are fecal matters, exposed fecal matters, and also where there are what? So the fly that you're seeing on your screen is what we call the Wolfachia domestica, okay? And the disease that you're seeing, you see that there are like maggots in the mouth of the person, okay? We are just enlarging it small. Yes, these are diseases that are real, okay? They exist. So the person who is having this disease is having what we call myiasis. So this is how the myiasis appears, okay? And the fly, we have already shown that. And we said that the adult form of the fly normally will lay their larvae on the skin of a person, and that larvae will what? Will start growing in that person, okay? And then they will be what? Live, like those maggots that can be seen in dead animals or maybe fecal matters and stuff like that. They can be seen in human body too. And once you see that a part of the human body is having a lot of these larvae, they are called myiasis. Now, some medical benefits about this myiasis. It is believed that whenever there is a chronic ulcer, okay, and you see these live larvae on it, these live larvae will cause what we call debridement. So they eat the dead tissues, and it is very good for the wound. So there are some trauma and orthopedic surgeons, when they see this, they are not in a haste to clear it from the site of infection. They sometimes allow it to do the natural debridement for some time. Because for them, when they are doing that debridement, it is not as painful as sending the person to the theater to actually do the surgical debridement itself, right? So some laboratories tried developing lab samples of these larvae to see if they can be used to cause debridement, okay? So even though it's a disease condition, but there are some medical benefits as well. So the name of that fly is called Wolfachia domestica. So keep the name of the fly in mind. They are not just like any house fly. They are bigger than the house flies, okay? So let's move on to the next question.
Next picture.
Next question. Or the question so that you see it. So we have some, it's already 4 o'clock, and all right, so the answer here is going to be the Olfactia magnifica, okay? The magnifica, not the domestica. Musca domestica is the normal housefly, sorry. And we have the Wolfachia magnifica. So please, let's move on to the next question. Please just give me extra 30 minutes to finish it for today so that we'll be done with the 20 questions for today. After the, when it's 4:30 and we are not done, we'll stop wherever we've gotten to. So a 9-month-old baby is on formula feeding. Formula used to feed the baby is imbalanced in 8B6 vitamin content. The child presents with convulsions that are likely to be caused by disturbed formation of. So give me a bigger screen and let me explain something here. So remember we said that usually there is an what? Impulse generation. Now, first of all, let's explain what convulsion is. So convulsion is an uncoordinated increase in what? Impulse generation in the central nervous system. Okay, that leads to what? Uncoordinated what? Muscle contraction and what? Relaxation, right? So when there is hypergeneration of those impulses, ideally, they are supposed to be inhibited. We spoke about that one earlier today. Okay, and there are a lot of inhibitions that has to occur. Okay, but remember we said that some of the inhibition will lead to the release of what we call the neurotransmitters that will cause the inflow. When those neurotransmitters bind to its receptor, it will cause the inflow of chloride ions, right? Chloride ions. And when chloride ions get inside the nest cell, then the inside will become what? More negative. Hyperpolarization will occur. So we've spoken about this thing. Hyperpolarization will occur. That means that inhibition will occur, right? Normally, our body prevents us from getting into convulsive states. So whenever there is increase in impulse conduction, the body will release some neurotransmitter called gamma aminobutyric acid, or simply GABA. When GABA binds to its receptor, it allows chloride ions to go into that cell and send it into a state of hyperpolarization and inhibits the cell. When it inhibits the cell, then there is going to be what? Low reduction in what? The impulse conduction. And when there is reduction in impulse conduction, this convulsion is terminated. That is how our body prevents us from getting convulsions. However, this GABA aminobutyric acid is produced from the amino acid called glutamate, okay, or glutamic acid, through a process called what? Decarboxylation. Okay, now this enzyme called the glutamate decarboxylase, okay, the enzyme that is catalyzing this reaction needs the vitamin B6 as its coenzyme. So when you don't have vitamin B6, it means glutamic acid cannot be converted to what? GABA. Okay, the enzyme is called glutamate decarboxylase. Okay, so when you don't have when you don't have the glutamate decarboxylase, then you can't produce GABA, right? And in that case, you need B6 to also activate the glutamate decarboxylase. So if someone is lacking, especially a child who is lacking B6, it means glutamate decarboxylase cannot effectively convert glutamic acid to GABA through decarboxylation reaction. Okay, so it means that the GABA will not be there to also cause hyperpolarization of the cells to inhibit their conduction, and that will lead to what? Convulsion. Okay, does anybody have any question? Let's move on. So the answer is going to be E, GABA. The child presents with convulsion that are likely to be caused by the cell formation of GABA. Okay, let's move on. So there's a picture for it. A 25-year-old woman was hospitalized into the gynecological unit. She needs a surgery for removal of ovarian tumor. During the surgery, it is necessary to cut the ligament that connects the ovary to the uterus. So we want to name this ligament. We want to see the ligament that connects the ovary to the uterus. And that ligament is called the ovarian ligament, okay? So we'll show you a picture of the ovarian ligament. And as you can see here, okay? And as you can see here, this is the ovary, and this is the uterus, okay? And then the ligament which is connecting the uterus to the ovary to the uterus is called the ovarian ligament, okay? So let's move on to the next question. Okay, so human immunodeficiency virus has on its surface antigen GP41 and GP120 and interacts with target cells of the body. Specify human lymphocyte antigens with which viral GP120 develops complementary bond. So bigger screen, please. Let me draw something small here. Okay. All right, so I'm trying to draw the HIV virus, right? The HIV virus looks something like this. It has a nuclear envelope, okay? It has an envelope first, and it has a capsid, right? And in the capsid, we have some DNA, RNA. It's not DNA, RNA. And that RNA is also protected, and we have some enzymes, okay? We have the integrase enzyme, we have the protease enzyme, and we have the RNA-dependent DNA transcript polymerase enzyme. Now, this is how, and this part here is the bilipid membrane, okay? So I'm not going to write, this one is the bilipid membrane, this one is the envelope, this one is the capsid. These ones here are the RNA materials. These small products here are enzymes. We have the proteases, we have the RNA-dependent DNA polymerases, and we have the, what's the name? So I'll remember the name and then just tell you right now. However, on the surface membrane, we have some other proteins projecting like this. All right. And these proteins, we call it spikes, okay, spike proteins. All right, so these spike proteins, this black one here is called GP120. Okay, and the red one here is called GP41, right? So let's just imagine, you know, the HIV virus affects our T cells, right? And on our T cells, we have a receptor called the CD4, right? And we also have another receptor called the CCR5. Okay, so this is the CD4, right? So whenever there is going to, whenever this HIV virus wants to enter in here, first, this GP120 first have to communicate with the CD4 here. Okay, so the CD4 will form some kind of bond with the GP120, and after which there will be what? A co-stimulation by this CCR5. Okay, whenever that co-stimulation occurs, it kind of pulls the virus close to the membrane of the T cell, right? And whenever that happens, it means that we can have the virus coming close. And when it happens like that, this GP41 will now undergo some conformational change and cause the fusion of the viral lipid membrane to the lipid membrane of the T cell, right? So what is going to happen is that, so now let me just draw some schematic picture of the virus here, okay? And remember we have, okay, so we have this thing attaching here, and whenever that happens, okay, so we have the other substance inside like that, okay? So whenever that happens, when there is this reaction, this is what is going to happen. So you have the virus fusing, okay? Fusing with the membrane like that, having all the substances in it, and eventually we are going to have these things like that. And what is going to happen to this? It will first release this substance of the virus inside here, right? It will break down. This RNA will be converted to DNA, and this DNA will now be fixed into our normal human DNA, and it will be used to produce some mRNAs, okay? And some those mRNAs, some will be converted back to the viral RNA. Some of them will be read to produce new proteins, okay? These proteins that we spoke about, the proteases, and we have the RNA-dependent DNA polymerase, and we also have, what's the name of this protein? I just forgot the name. It's actually, what it does is that the function of that protein is to insert our DNA, the viral DNA, into our normal DNA. Okay? I just forgot the name of that protein. When I remember, I'll tell you. So you produce all those DNAs, proteins and everything, and then the virus will reassemble and bud out. Okay? When they bud out, they take part of the cell cytoplasm and form another lipid membrane, and new virus has been generated like that, and it can go ahead and infect other cells. Okay. So the question was saying that this GP120, which of these cells on the T cell membrane will it interact with? First, it will interact with the CD4 before the CCR5 will also cause co-stimulation, and then these cells will fuse with the membrane. Okay, so the answer is going to be CD4. Please, let's move on. So a sick child presents with high content of phenylpyruvate in urine. Normally, it is practically absent. Blood phenylalanine level is 350 milligram per liter. Norm is 50 milligram per liter. What disease are these symptoms characteristic of? That is what we just spoke about. That when you see phenylpyruvate in the urine and in the blood, it means that the person is having what? Phenylketonuria. So there's no need to waste much time here. So let's move on. A radioactive isotope was introduced into the symptom of artificial cell culture. What organic substances can accumulate this isotope? So they are saying that a radioactive isotope called phosphorus. So phosphorus, the chemical structure of phosphorus is what? P. So go to the next picture. No, the next one. Wait, I want to explain something. No, the next picture.
Yeah.
Okay, go down. This one first. The P first. So everybody knows that phosphorus is what? P. And whenever phosphorus is in the form of functional group or having an interaction with some hydroxyl groups, we call it what? Phosphate, right? So we will show you a picture of the phosphate form. So this is how phosphate is, okay? So whenever it is in bond with some hydroxyl and oxygen group, we call it phosphate. So this is how phosphorus will be incorporated in our normal tissues, right? And which of our normal tissues usually have phosphate as part of it, right? So we have our nucleic acids. Some of our nucleic acids are the ATPs, the AMPs, the ADPs, the DNAs, the RNAs. You understand it? Those are nucleic acids. So let's look at a picture of the nucleic acid. So you realize that this is a nucleic acid, which is having what? A phosphate backbone. And you can see that we have what? The nitrogenous base plus a ribose sugar. Okay, so that makes up the nucleic acid. But the other ones like the carbohydrates and then the amino acids, they don't have phosphate as part of their structure. So where the phosphorus will accumulate will be in our nucleic acids. Okay, so let's move on to the next question. Okay, so monoamide oxidase inhibitors are widely used as drugs. They change the level of nearly all neurotransmitters in synapse with psychopharmacological, the following neurotransmitters being the exception. Okay, so bigger screen. All right. So the other time I drew, so I'm drawing this thing, the synapse again, okay? And here, this one is called synaptic cleft, right? Now, I said that normally neurotransmitters are produced like the catecholamines, okay, from tyrosine, right? Remember we said tyrosine will be converted to what? L-dopa by the tyrosine hydroxylase, and it will undergo decarboxylation to form dopamine. And dopamine here, so hydroxylation, decarboxylation, right? Dopamine here can be converted to, so it will be pumped into some vesicles, and inside the vesicles, they can be converted to what? Adrenaline and noradrenaline, right? And noradrenaline. So these ones will be what? will be inside the vesicle. And normally, they are inside the vesicle for a reason. Okay? Remember that this enzyme, this amino acid called tryptophan, okay? Tryptophan. Tryptophan 2, so I can't write everything here, so I'll use T to represent tryptophan. So tryptophan. Tryptophan 2 can be converted to what? Serotonin, right? And all these neurotransmitters too are found in the vesicles, right? And in the vesicles, whenever there is action potential for them to be released, remember calcium will come in, bind to it, then move the VAMP to bind to what? The syntacin, right? And they will now release through the process called exocytosis, right? Release these neurotransmitters here. Now, why is it that these neurotransmitters are in the vesicle? Because inside the cytoplasm, okay, there is an enzyme called monoamine oxidase. What they do is that they look for free amines. Okay, they look for these free amines, and then they break it down when they are not inside vesicles, right? So what they do is that, remember, how do they get the free amines? Remember that in the synaptic cleft, there is some reuptake here, reuptakers here, proteins. What do? They reuptake serotonin. Some are selective to serotonin alone. Some will reuptake what? Serotonin and noradrenaline. When they pump them here, when they pump them from the synaptic cleft here, back into the cytoplasm here, these serotonin and noradrenaline should be pumped back into the vesicles. If they are not pumped back into the vesicles early, this monoamine oxidase will break them down. So these, if you want to, and you know, this serotonin, adrenaline, dopamine, and stuff like that, they are the hormones that allow us to feel what? Happy, right? So people who are having depression, okay, they are always sad. You want them to have a lot of noradrenaline, dopamine, serotonin in the synaptic cleft in order to stimulate those post-neuronal fibers so that they will also feel happy a bit. Okay, so naturally, we have some drugs that will reuptake them, right? Or, I mean, an enzyme that will reuptake these neurotransmitters. That is how it works. But because these monoamine oxidase are there, they break them down. So what they do is that they give a drug that will inhibit the activity of the monoamine oxidase. And if you do that, it means this dopamine, serotonin, adrenaline, noradrenaline, which have been reabsorbed back into the cytoplasm, can now be pumped actively into the vesicles and can now be released again, right? So you don't need to form these neurotransmitters from scratch again, which takes a lot of time, right? And in that case, you give the monoamine oxidase inhibitor. Does anybody have any questions? So let's move on to the question. All right. So the answer here, so you see the neurotransmitters that the monoamine oxidase can work on are the dopamine, serotonin, adrenaline, and noradrenaline. Acetylcholine does not have these type of monoamine oxidase in their synaptic knob. Okay, rather in the synaptic cleft, they have what we call acetylcholinesterase that breaks them down. Okay, so you don't need that. You don't need monoamine oxidase to break down acetylcholine. So here, the answer here is going to be the exception of all those drugs that monoamine oxidase can work on is acetylcholine. Acetylcholine is the exception, okay? Monoamine oxidase can work on dopamine, noradrenaline, adrenaline, and serotonin, except acetylcholine. That's why the answer is acetylcholine. Wow. So finally, the last question. Let's move on to the last question and then. All right. So during removal of hyperplastic thyroid gland of a 47-year-old woman, parathyroid gland was damaged. 1 month after the surgery, the patient developed signs of hypoparathyroidism, frequent convulsions, hyperreflexia, laryngospasm. What is the most likely cause of the patient's condition? So first of all, we'll just do some simple explanation here because I know we are all exhausted. And like I said, it's a simple explanation, but next time when we get similar question, we'll have to explain why the patient is having convulsion and laryngospasm and everything, okay? So first of all, we have the thyroid gland, okay? 2-lobe gland, which is separated by what we call isthmus, okay? And it sits just in front of your thyroid cartilage, okay? Now, when you flip it at the back, so when you look at it from the anterior part like this, okay, you can palpate it here, okay? Now, when we take it out and we turn it at the back, so we, not on this space, but we've turned it this way, you realize that it is having some 2 upper glands and 2 lower glands. These glands here are the parathyroid gland. They are para to the thyroid gland, okay? So parathyroid gland. So if you are taking out the thyroid hormone, there is no way you can take out the thyroid hormone and leave the parathyroid alone. You have to take everything because they are together, right? But the function of this parathyroid hormone is that whenever there is what? Hypocalcemia, right? Whenever there is hypocalcemia, what does that mean? Low calcium level in blood, right? This parathyroid gland is stimulated, okay? When it is stimulated, they produce a lot of what? Parathyroid hormone. And when they produce the parathyroid hormone will, 1, go to the bone, okay? And 2, which will also go to the kidney. What does it do at the bone? It increases the activity of what we call the osteoclast, okay? Osteoclast is a bone cell which will cause the resorption of the bone, okay? Because normally we are depositing new bone and the deposition is caused by osteoblast. So this is how the bone grows, okay? This is a bone, fresh bone. Osteoblast will be depositing new bone like this all the time, depositing new bones like that. And the osteoclast is always inside the medullary part, and it will also be dissolving the old bone which was inside, okay? So osteoblast will do new deposition, and osteoclast will be inside dissolving the old bone, right? So when it dissolves the old bone, what do they release? Calcium. We spoke about it earlier. So the osteoclast its activity will increase, right? And it will start dissolving old bones and release a lot of calcium. And this calcium will now increase in the blood, okay? So what does that mean? It means that because the calcium level decreased in the blood, parathyroid hormone was released by parathyroid gland to cause increase of what? Calcium in the blood, right? In the kidney, it will cause the reabsorption of what? Calcium. To increase what? Calcium reabsorption. Calcium reabsorption in the kidneys. So that one too will lead to what? Increase in calcium in blood, right? So the function of the parathyroid hormone is to cause increase in what? Calcium level in the blood. whenever calcium level goes down. So if you are doing a surgery and you remove the parathyroid gland, okay, whenever calcium level goes down, it means that whenever calcium level goes down, there is no parathyroid hormone to even release parathyroid gland. Parathyroid gland to release parathyroid hormone. And what is going to happen is that this hypocalcemia will not be corrected. So when this hypocalcemia is not corrected, then the patient can have a lot of clinical presentation. So here, because there is no parathyroid gland, no parathyroid hormone is released, hypocalcemia cannot be corrected. So in the blood, calcium level will still be low. And the normal calcium level in the blood is usually around 2.5 millimole per liter. Okay? So below that, okay, below that is called hypocalcemia. Okay? Calcemia, not like that. Okay? When you have hypocalcemia, what is going to happen? Your neural cells becomes excited. Your muscle cells becomes excited. When your neural cells become excited like that, they can cause what? Convulsion. So there is excitability in your neurons and it will lead to what? Convulsion. There is excitability in your muscles and it will lead to what? Muscle cramps. Okay? Or spasms. Muscle spasms. Okay? There can be increase in what? Urine output. There can be a lot of other clinical presentations. So the moment you see convulsion, laryngeal spasms, and other stuff like that, then it means that there is likelihood of the person having defect in the control of calcium in the blood. And one of the control mechanisms is the parathyroid hormone, leading to reabsorption of calcium from the kidneys and also increased resorption of calcium from the bones. I said one of them because remember, vitamin D will help or increase in the calcium reabsorption from the GIT, right? So in hypoparathyroidism, there is hypocalcemia. And in hypocalcemia, there is convulsion and muscle spasms. And some of the spasms will be what? Laryngeal spasms and other things. Can you please project a question and let's answer it and close for the day. So during removal of the hyperplastic thyroid gland of a 47-year-old man, the parathyroid gland was damaged. 1 month after the surgery, the patient developed signs of hypoparathyroidism, that is frequent convulsion, hyperreflexia, laryngeal spasms. What is the most likely cause of the patient's condition? And the answer is going to be hypocalcemia. Does anybody have any questions so far? All right. So even if you have some question, you can send it to me in my private number. And I hope those who joined us today enjoyed the class. And I believe that all of you have been enjoying the class every day. So I will encourage you to keep on practicing. I was really impressed by the performance yesterday, but don't be swollen-headed. You still have to practice more, right? So there should be a lot of practice, okay? And like I said at that time, those who have already practiced from 2010 up to 2019, start from 2003 and move forward up to 2019. Just keep on practicing, okay? Just keep on practicing because after we finish discussing the 2020 questions, then there is going to be another exam, like what we did last Saturday, okay? And that one is going to range from 2003 up to 2019, okay? So we want you to familiarize yourself with a lot of the questions and leave the explanation to me, okay? The ones that you can do the explanation yourself, fair enough, you can do it, okay? But keep on familiarizing yourself with the questions, okay?